Hi guys, welcome back to my YouTube channel. My name is Uche Kennedy, and in today's video I'm going to introduce you to something interesting. I'm going to be posting videos from the last bootcamp session we had sometime last year. A lot of you have been asking me about when the next bootcamp is going to be starting. That is still in the works, but for the meantime, the videos that were recorded in the last bootcamp session are going to be uploaded here on YouTube. A number of them, slowly but surely, we are going to try to edit them a bit and try to provide them here on YouTube, so that those of you that have been looking forward to them will be able to see them. A quick background though: initially the bootcamp was intended to be a very fast-paced accelerated program that would just run for a duration of 10 weeks and everybody will be ready for the exam. But when these students began filling in their details before we started the bootcamp, I realized that most of them were scoring very low. Some of them were scoring as low as 160, 150s on the MBMs, meaning that these people are not ready for such fast-paced review system. So we decided to do a teaching program. So what you're going to see in these videos is going to be me basically teaching a lot of the information that you're going to need to know for this step one. Now, these videos have been curated and are organized in such a way that the chapters follow how your first aid is organized. I try to make it as close as possible so that it's easy to actually use both resources together. You're going to have access to them, you're going to be able to use them. If you want access to everything in one, click on the link down below, sign up on my website, and you'd get access to the notes as well, not just the videos. So the videos will be here on YouTube, but you have access to the notes, all the handwritten notes I have done, you would get them there. And then in addition, please beware that a lot of the information I'm going to be explaining to you here are going to be explained in the way that I think of the material. So I'm not teaching you from a slide, I'm not teaching you from a textbook or something. I tried as much as possible to provide as much information as I can think about while teaching this. So this is how I would approach the material. This is how I interpret a lot of the information as long as the step one is concerned. So you want to think of it in that manner, you want to approach it like that. So don't expect to see details the way you see them in your pathology textbook or something of that nature, because that is not the point of this studies at all. That is not the point of this lecture series at all. As much as you can, I hope you remember everything we do. I hope you understand everything I have covered. I have tried to break them down as simply as possible. If you have any questions about any of these videos, please leave them down below. If there's any particular video you would like to see, maybe faster, because if we like, the first video is going to be cardiology. By the time we finish editing and releasing every other video, it's probably going to take a while. So if there's any video you think you want to see urgently, leave a comment down below and I'll take it into consideration, and hopefully that video will be made available. Again, if you want to get access to all the notes and all the other videos that are recorded, click on the link down below, get on the page, just sign up, and you'll be able to get access to those. Until next time, I will see you soon. Enjoy this video. Cardiology. We'll start on the development of the heart. When the heart developed, we began with a primary structure that would look like that, right? You would remember that we had to form an atrium and we had to form a ventricle. The atrium started with an outgrowth somewhere up here. You don't need to know all these things, so I'm just saying this to give you a background. They are not important for your exam. So that would have a structure as to how we get to anywhere we get to. So your atrium started with a septum primum somewhere up here. We had the first septum that came up to sort of divide your atrium into the right and left atrium, the septum primum. The septum primum grew down, and as it grew down towards a set of tissue, or a little tissue we had down here. I hope you remember that this is the endocardial cushion. The endocardial cushion was a derivative of neural crest cell. As the septum primum grows down towards the endocardial cushion, if you remember, there was an opening that was formed in the middle of your septum primum that we called the foramen primum. And then the lower part of the septum primum grows to fuse with the endocardial cushion. We had a second septum begin to grow right on the side of the septum primum. That was the septum secundum. I'm going to be describing some of these things, and then at a point I'm going to just skip a whole portion because it's actually irrelevant to you, and then we'll get to the chase of we'll cut to the chase to exactly what we want to get to. The septum secundum developed down there, and then you would notice that as your septum secundum grew down, we actually have this opening here. It's like we can create a connection for blood to flow from the right atrium into the left atrium. This opening that is formed by the septum secundum was called the foramen secundum. It's like the second opening. A foramen is an opening, so it's like your second foramen, your second opening, foramen secundum. That opening or that pathway connection between the right and left atrium that was formed with the help of your foramen secundum, with the help of your septum secundum, called the foramen secundum, became eventually what we would know as the foramen ovale. At the end of the day, all I needed to remember is that there was a septum primum, there was a septum secundum. You don't need to know the order of how they came about. And then ultimately, there was a foramen ovale. The foramen ovale was the last foramen that was present during the formation of, or the division of the atria into right and left atrium. You have your foramen ovale. Now, the way we come up with pathologies is that we look at a normal process and we ask, what if this normal process does not occur? So the question you should be thinking to yourself is, okay, we are supposed to have a septum primum, we are supposed to have a septum secundum, we are supposed to have a foramen primum, we are supposed to have a foramen ovale. All right. What if any of these things go wrong? That's the question you should be asking. If the septum primum did not develop, or the septum secundum did not develop, what's going to happen? Then we have a pathology, right? So pathology is basically an abnormality of normal processes. If something is supposed to happen and then it did not happen, we say that we have a pathology. When the child is born, the septum, because when a child is in the womb to start with, there is higher pressure on the right side of the heart and lower pressure on the left side of the heart. And there is a reason for this. When the child is in the womb, the lungs are not active. If you remember from all the information you've gathered in med school, if this is your heart, the lungs bring blood back to the left side of the heart. And that's how the left atrium gets its own pressure. But when the child is in the womb, this child is not breathing, it's not respirating. So there's no pressure on the left side of the heart. Blood comes into the right side of the heart from the umbilical arteries, right, that are coming from the mother. And so there's higher pressure on the right heart than there is on the left heart. So naturally, blood is going to flow from the right to the left in this patient or in this child. Blood is going to flow from the right to the left. However, when the child is born, we want this process to reverse. Immediately the child takes the first breath, there's going to be increased oxygen tension within the lungs. When you increase the oxygen tension within the lungs, blood is going to flow into the lungs. The pulmonary arteries that were shut when this child was in the womb because the child wasn't using the pulmonary arteries, these pulmonary arteries open up, pulmonary veins open up, blood now flows back from the lungs into the left ventricle. The pressure within the left ventricle increases. And what you're going to see is something like this. If this is the heart, we have the atrium, we had septum primum, I think I put them on the opposite side before. We had septum secundum. When the pressure reverses, pressure on the left heart pushes against the septum secundum and closes off this foramen. So you expect these two to fuse together, something like this, right? They come together and they fuse like that. That is what is supposed to happen. There is higher pressure on the left at birth than there is on the right. Again, if this process does not happen, then we have a problem. This foramen is going to remain open, and that means that blood can potentially flow from the right side of the heart to the left side of the heart. That abnormality is what we call foramen ovale, persistent foramen ovale, or patent foramen ovale. How will they ask you this a question on your exam about patent foramen ovale? They're going to give you a patient. This patient may not be a child because naturally, if the pressure on the left increases in most of us, these two are supposed to fuse permanently. They're supposed to fuse and become completely locked, impossible to separate. In persons with patent foramen ovale, the septum secundum does not completely fuse with the septum primum, and so they're going to have an opening between these two places. The valves are closed, the septums are fused, but they're not completely fused, meaning that if something happens in adult life and there's an exchange or a switch in pressure, potentially this septum can still be separated. This septum, let me see, the septum secundum can still be separated from the septum primum in the future, right? So it may be a 20-something-year-old patient, it may be a 40-year-old patient, it may be a 60-year-old patient, and something will go wrong. The pressure in the right side of the heart will increase for some reason, and this septum will move apart, open up, and blood will be able to flow from the right to the left. Other than that, patent foramen ovale is often asymptomatic. So what do you expect to see on your exam as a question related to patent foramen ovale? I'll give you this. They'll give you a 45-year-old man, that was in a flight for 8 hours, basically developed DVT. If you know anything about DVT, you remember that people with DVT go ahead, usually you've memorized by now, that they go ahead to develop pulmonary embolism. Why do they go ahead to develop pulmonary embolism? Because when you have deep venous thrombosis in your lower limb, remember that's where they form. The thrombus that forms in those deep veins ends up in the right heart and then gets into the right ventricle rather. And then from your right ventricle, they're going to be pumped into the lungs. When they get into the lungs, then they cause obstruction, we call pulmonary embolism. But in a patient with patent foramen ovale, there is a likelihood that because blood can flow from the right to the left, a thrombus from the leg veins, from the deep veins of the lower limb, will come into the right side of the heart, and then this thrombus will end up in the left ventricle, in the left atrium. If it gets into the left atrium, it moves into the left ventricle, and then the left ventricle pumps this thrombus through the aorta to other parts of the body. So if I give you a patient with DVT, but you're reading the vignette, and instead of this patient developing pulmonary embolism, they tell you that this patient developed a stroke. What does that mean? The thrombus moved from the right atrium, into the left atrium. From the left atrium, it moved into the left ventricle, and then the aorta was obviously used to pump this thrombus to other parts of the body. If it gets into your carotid arteries, for example, it would head for the brain and cause a stroke. If it does not go to the brain, it's going to go to other end organs in the body and cause ischemia to those parts of the body. But most times on your exam, they're going to give you a stroke. So patient with DVT develops a stroke. What's the most likely diagnosis? A patent foramen ovale. Sometimes this type of stroke is called a cryptogenic stroke. This kind of stroke is going to be called a cryptogenic stroke. That is how the foramen ovale plays a role. And this is what you need to remember about a foramen ovale. There are no murmurs in foramen ovale. We don't diagnose it until something of this nature occurs, or for some reason we decide to do an echocardiography and they could actually detect that there is a patent foramen ovale. The second thing we want to talk about is going to be development of the ventricles. That's probably more important for you. So there are two parts to a ventricle. Of course, we have the right ventricle and we have the left ventricle. That is a thick muscular tissue. Separating these ventricles are the interventricular septum. And your interventricular septum is composed of two parts. We have the lower portion, that is the muscular part. The lower portion is the muscular part of your interventricular septum. But we have a membranous section to your interventricular septum. The membranous section, if you remember somewhere up here, we talked about the endocardial cushion. The endocardial cushion contributes to the membranous section or the membranous portion of your interventricular septum. So right here is the membranous part of your interventricular septum. Here's what you want to know. People with trisomies or chromosomal abnormality, any chromosomal abnormality at all, are likely to develop endocardial cushion defects. So you want to associate trisomy 21, for example, which is Down syndrome, with endocardial cushion defects. So let's think of it this way. If for some reason there's an endocardial cushion defect, remember this is the endocardial cushion, it means that the membranous part of the ventricle is probably not going to form. The membranous part of your interventricular septum is not going to form. If this part of your interventricular septum does not form, there will be a communication between your left ventricle and your right ventricle. So we have the muscular part, but now this portion is open. We have a communication between your left ventricle and your right ventricle. This is what we call a ventricular septal defect. A ventricular septal defect. Failure of the membranous portion of the interventricular septum to form completely. Now, there are different degrees to which a ventricular septal defect can occur. There are times when the septum will be completely absent. If the septum is completely absent, we'll have a large ventricular septal defect. This patient is probably going to present a little earlier in life, in childhood, maybe by the time they are 5, 6, 7, or thereabout. There are also times when the defect is going to be very small, right? The defect will be very small. Imagine we have just this large of an opening, pretty small, right? People like this may not present until much later in life. And there are times when the defect is so small that it actually heals spontaneously by itself. We would never notice that this patient ever had a ventricular septal defect. What happens when there is a defect? There is communication. There is communication between your left ventricle and your right ventricle. When the child is in the womb, once again, you want to remember that the pressure in the right side of the heart is much higher than the pressure on the left side of the heart. So there's usually no problem when the child is still in the womb. However, when the child is born, the pressure in the left part of the heart becomes higher than the pressure on the right side of the heart. So you expect blood to flow from the left ventricle to the right ventricle. You expect blood to flow from the left ventricle to the right ventricle. And that's what happens in a ventricular septal defect. Now, because the pressure on the left is significantly higher than the pressure on the right, blood is going to flow into the right ventricle throughout systole. Whenever the left ventricle contracts, or whenever the heart contracts as a whole, the pressure on the left ventricle will be so high, it will push significant amount of blood into the right ventricle throughout systole. Remember that when the heart contracts, it is called systole, right? So systole is contraction, basically, right? Diastole is relaxation. So you want to bear these basic definitions in mind. When the heart contracts, again, blood is going to flow across a VSD. This is a VSD here, a ventricular septal defect. And whenever there is a defect in any tissue that is a part of the cardiovascular system, you're going to hear a murmur. Whenever there's a defect in the cardiovascular system, you're going to hear a murmur. If a vessel becomes too narrow, you will hear a murmur. If a blood vessel becomes too wide, you will hear a murmur. If a valve becomes too narrow or too stiff, you will hear a murmur. If a valve becomes too flexible, regurgitant, we'll talk about all that, you will also hear a murmur. So when we have an interventricular septum that is now open, you expect to hear a murmur. Does that make sense? You expect to hear a murmur. What kind of murmur do you want to hear in a person with a ventricular septal defect? Because, again, the pressure is significantly higher on the left part of the heart and blood is flowing into the right part of the heart, every time there is systole or contraction, blood will flow across this defect throughout systole. If blood is flowing across the defect throughout systole, we will call that a holosystolic murmur. Holosystolic. A murmur that continues throughout systole. If someone is going to draw a diagram to show you what the murmur looks like on a phonogram, for example, they're going to show you something like this. Something like this, right? You're going to hear the murmur between S1 and S2. We'll talk about what S1 and S2 are eventually. S1 is the first heart sound, S2 is the second heart sound, and you're going to hear your VSD throughout that period. The time frame between S1 and S2 is systole. You want to also bear that in mind, right? So that is how a VSD is going to form. We've seen the VSD, we've seen the patent foramen ovale. What next do we need to look at? Your endocardial cushion, apart from forming the membranous part of the interventricular septum, contributes to the formation of the valves. So if you remember from your cardiovascular system, the left side of the heart, between the left atrium and the left ventricle, has the mitral valve. On the left part of the heart, between the left atrium and the left ventricle, we have the mitral valve, right? And blood is supposed to flow from the left atrium into the left ventricle across the mitral valve. This mitral valve, part of its formation is development of the endocardial cushion. So whenever there's a problem with your endocardial cushion, already you can tell that there may be a problem with the mitral valve, there may be a problem with the membranous septum, the membranous portion of the interventricular septum, there may be a problem with the tricuspid valve. On this part, remember we have the mitral valve. Please take note of these anatomical positions so that you're going to follow us when we go into other areas. On the right-hand side, the same position where you have the mitral valve, we have the tricuspid valve. Whenever there is closure of the mitral valve or the tricuspid valve, we hear a sound. That sound is the S1. So the S1 heart sound is as a result of closure of the mitral valve and the tricuspid valve. For the purpose of the exam, I would want you to only remember that S1 heart sound is made when there is closure of the mitral valve, because most of the time on the exam, we are going to be talking of the left side of the heart more than we'll be talking about the right side of the heart. All right. Then we also talk about the endocardial cushion contributing to forming your atrium. It also forms part of your atrial septum. So we spoke a lot about the atrial septum. We didn't really talk about the contribution of the endocardial cushion. There are also contributions. You want to just know that. You don't have to remember it. Contributions made from the endocardial cushion to the atrial septum, the interatrial septum. Again, if there is endocardial cushion defect, this part of the endocardial cushion that contributes to the atrium may not be present. And if it's not present, a person or a child will present with atrial septal defect. That's your ASD. So ASDs will occur when the portion of the atrial septum that is contributed by the endocardial cushion is not present or does not form properly. That is when we have an atrial septal defect. And people that are going to have atrial septal defect more commonly would be people with rubella infection. So if the mother had rubella infection during pregnancy, the child is at very high risk of developing an atrial septal defect. This is very important for your exam. You want to remember it. Let's see the consequences of both a VSD and an ASD. If blood is flowing across your ventricle from left to right, blood is flowing across a VSD from the left part of the heart to the right part of the heart. The implication is that the right ventricle will be doing a lot more work. Imagine you're supposed to have 5 liters of blood in the left ventricle. You're also supposed to have maybe 5 liters of blood in the right ventricle. But now, during systole, when blood is supposed to be leaving your left ventricle, let's say 3 liters left the left ventricle, for example. But we have 2 liters moving across this valve into the right ventricle. Now the right ventricle is no more pumping 5 liters of blood. It's going to be pumping 7 liters of blood. That's the 5 liters plus the 2 liters, right? That's what happens in a VSD. And as the right heart pumps 7 liters instead of 5, it will be doing significantly more work, right? The right ventricle will be doing significantly more work, pumping 7 liters of blood across into the pulmonary artery. We'll look at that eventually, the pulmonary trunk. This right ventricle that is now pumping more blood than usual, just like when you go to the gym and you lift more weights than you usually lift. If you're just at home, you're lifting a pen and a plate. When you go to the gym, you're now lifting 20 kilogram, 50 kilogram. What happens? Your muscles begin to grow bigger. The same thing happens to the heart. The heart lifts weights, and the weight of the heart is the amount of blood it has to pump, or the amount of force it has to pump against. So if the right heart keeps pumping 7 liters for the next 2 years of the child's life, this right ventricle is going to become big. It becomes larger in size. What do we call that? A hypertrophy. We call that hypertrophy. Now, you remember from your general pathology, hypertrophy means that your individual cardiac myocytes increased in size. The individual cardiac myocytes, so the cells that make up the heart, the cardiac myocytes are going to increase in size, right? And as they all increase in size cumulatively, the size of the wall of the heart is going to increase. Compare that to hyperplasia. Hyperplasia is increase in the number of cells. Increase in the number of cells. If you multiply the number of cells, the organ will grow bigger. If you increase the size of individual cells, the organ will also grow bigger. So hypertrophy is enlargement of the organ as a result of increase in the size of the individual cells. Hyperplasia is increase in the size of the organ as a result of increased number of cells. And a good example of where you would have hyperplasia is in the endometrium. You want to remember that from the general pathology. Hypertrophy occurs in organs that usually cannot undergo additional division. They have already reached terminal divisive state. We'll talk about some of that eventually. Something like your heart, your skeletal muscle. These two especially undergo hypertrophy. They don't undergo hyperplasia, and you need to know that's the difference. However, let's go back to what we are talking about. So the left ventricle begins to grow thicker. Now we end up with a right ventricle rather. Sorry, the right ventricle begins to grow thicker, and now we end up with a right ventricle that is this thick and the left ventricle that is this thick. When the right ventricle becomes significantly thicker than the left ventricle, the pressure on the right becomes higher than the pressure on the left. This blood flow, remember the blood from the VSD was flowing from left to right. Now it's going to reverse and start flowing from right to left. When there is reversal of a shunt is a communication between two different compartments, right? A communication, a small communication or channel that connects two different compartments. So if you're connecting your left ventricle to your right ventricle, a VSD is a shunt. When this shunt reverses, blood now begins to flow from the right ventricle into the left ventricle. That is called Eisenmenger Syndrome. When there is shunt reversal from right ventricle to left ventricle, that is called Eisenmenger Syndrome. And we are going to see the consequence of having a shunt reversal. One of the things you want to take note of is this. If someone has a VSD, the blood in the left part of the heart is oxygenated blood. This is blood coming from the lungs. It has a lot of oxygen, right? One of the type of questions they ask on your exam is this. They give you 4 chambers. They give you 4 chambers. They tell you this is the right atrium, this is the left atrium, this is the right ventricle, this is the left ventricle. Normally, if blood is coming from your lungs and this blood is 90% oxygenated, you expect the blood in your left atrium to be 90% oxygenated, the blood in your left ventricle to be 90% oxygenated. The blood that comes to the right side of the heart is largely deoxygenated because the body has already used up all the oxygen and then blood is returning to the right heart. This blood may be, let's say, 10% oxygenated. So do you expect the one in the right ventricle to be 10% oxygenated because blood from the right atrium will flow into the right ventricle. You expect this to be 90, therefore this should be 90 because blood from the left atrium will flow into the left ventricle. Now, if you have a VSD, and you should take note of this, I'm sure you've seen a question on this before. If you have a VSD and there's a connection between the left ventricle and the right ventricle, oxygenated blood will flow from the left ventricle into the right and increase the oxygen saturation of blood in the right ventricle. It will increase the oxygen saturation of blood in the right ventricle. So instead of having an oxygen saturation of 10, for example, 10%, the right ventricle may have an oxygen saturation of, let's say, 25%. Because there is a mixture between oxygenated blood and deoxygenated blood. Well, the right ventricle is going to pump this blood into the lungs, and the lungs will oxygenate it even further. Now, We don't have much problem with this, right? Because the left ventricle will still pump blood to the rest of your body through the aorta. And as it pumps blood, this blood is still 90% oxygenated. So your organs are still going to get enough oxygen. However, when you now get Eisenmenger syndrome and there is a reversal of shunt from the right to the left, it is no more oxygenated blood moving from the left ventricle to the right ventricle. It's no more oxygenated blood moving from the left ventricle to the right ventricle. It's now deoxygenated blood moving from the right ventricle to the left ventricle. So if this blood is 10% oxygenated, when this deoxygenated blood begins to mix with oxygenated blood in the left ventricle goes from being 90% oxygenated to being, depending on how severe the VSD is, maybe 70% oxygenated. What this means is that your tissues, when this left ventricle pumps blood out through the aorta to supply your kidneys and your intestines and all those organs, these organs don't get the maximum oxygen supply that they are supposed to get. So these organs will have what? Hypoxia. Or, yeah, they will have hypoxia, right? The organs who have hypoxia, decreased oxygen supply to tissues, is called hypoxia, right? You want to remember that. Great. And when your tissues are not receiving oxygen, you feel symptoms, pain, if it's a muscle or whatever. The second thing you want to know is that because there is mixture here, the amount of oxygen in blood as a whole decreases. The amount of oxygen in blood as a whole decreases. When you decrease the oxygen tension in the blood or the oxygen saturation of blood, we call that hypoxemia. Okay, so someone will now ask me, what's the difference between hypoxia and hypoxemia? Very important distinction you have to make. Hypoxemia, emia is blood. Hypoxemia is decreased oxygen concentration in blood. And hypoxia is decreased oxygen supply to tissues. Important that you make the distinction. Hypoxemia is decreased oxygen concentration in blood. Hypoxia is decreased oxygen supply to tissues. Why is this important? When you breathe in, blood, oxygen gets into the blood. Okay, so if this is your blood vessel, for example, and this is the lungs, blood gets into the blood vessel, or oxygen gets into the blood vessel. This oxygen dissolves in blood. We have a red blood cell. Your red blood cells are floating around within the blood vessels. As this oxygen dissolves in tissue, in blood is fluid. I don't know how to represent this. Yes. As this oxygen dissolves in blood, it contributes to what we will call oxygen partial pressure. So when you hear them say partial pressure with small a of oxygen, what we are really talking about is oxygen dissolved in blood. From blood, this oxygen will load onto your red blood cells. The oxygen moves onto your red blood cells. Remember that within the red blood cells, we have hemoglobin. The oxygen loads onto your red blood cells, onto hemoglobin. Now, hemoglobin becomes saturated with oxygen. Hemoglobin becomes saturated with oxygen. That is what makes up oxygen saturation. So when you see PaO2 and SaO2, PaO2 is partial pressure of arterial oxygen. This is arterial oxygen. Should I write that up for you? Partial pressure of arterial oxygen. And SaO2 is oxygen saturation. It talks about the amount of oxygen on hemoglobin. Okay, so that's by the way. Let's get back to this guy. When there's Eisenmenger syndrome, you have a mixture of blood. The amount of oxygen here we said was 10, here was 90. When you mix them, here becomes 70. Your partial pressure for oxygen, there's a decrease in the partial pressure of oxygen in Eisenmenger syndrome. So patients with Eisenmenger syndrome are going to develop hypoxemia. If they develop hypoxemia, automatically they are going to have hypoxia. And whenever there is hypoxemia and hypoxia, the way we can tell looking at a patient is that the patient becomes blue. So they develop what? Cyanosis. So ultimately, what do you want to know? If a person has ventricular septal defect, there is a left to right shunt. Eventually, this left to right shunt reverses. We call that shunt reversal. And now there is a right to left shunt. Whenever there is a right to left shunt, there is hypoxemia, which is decreased oxygen saturation in blood. And when there is hypoxemia, the patient is going to present with, what do we call it? Cyanosis. Now, the time between when this patient is born with a VSD and when they develop cyanosis is usually a long time. So it doesn't occur in the first hours of birth. It doesn't usually occur even in the first few weeks of birth, except it's a very large VSD. Therefore, a VSD is characterized as one of the late cyanosis or cyanotic diseases. A VSD is characterized as one of the late cyanotic diseases. So you have to have a VSD, and then we wait until your right ventricle undergoes hypertrophy, and then there is shunt reversal before this patient is going to develop cyanosis. The same thing occurs for an ASD. When there is an ASD, at first, when the child is born, the pressure in the left part of the heart is greater than the pressure in the right side of the heart. So you have a left to right shunt. And then, again, we have a shunt reversal, and it becomes a right to left shunt. And because of this shunt reversal, it's exactly the same thing. We develop hypoxemia, and the child presents with cyanosis. So again, ASD becomes a late cyanotic heart defect. Okay, ASD and VSD are late cyanotic heart defects. We already talked about the murmur of VSD. We said you have a holosystolic murmur. We should talk about the murmur of ASD and why it is very important. When there is an ASD, blood is flowing from the left heart to the right heart. This blood is going to flow across the tricuspid valve into the right ventricle. Here's something you need to know. We talked about S1 and S2. And I said S1 heart sound is as a result of the closure of the mitral valve and the tricuspid valve. S2 heart sound is as a result of closure of the aortic valve, we would see later, and the pulmonary valve. It's as a result of closure of the aortic valve and the pulmonary valve. You want to remember that the aortic valve is on the left part of the heart. We'll see a diagram of the heart in a bit. The aortic valve is on the left part of the heart. And this aortic valve is under higher pressure. The aortic valve is under higher pressure than the pulmonary valve, right? The aortic valve is under higher pressure than the pulmonary valve. You want to remember that. What that means is that the aortic valve is going to close faster than the pulmonary valve. So when we represent the closure of the aortic and pulmonary valves, we do something like this. So this will be the aortic valve, and this will be the pulmonary valve. We say that the aortic valve constitutes the first component of the S2 heart sound. Okay, so if you listen very closely to that heart sound, you would pick up the time difference. Not for you to do it much later in your medical career, but you could pick up that there is a slight difference. The aortic valve closes and then the pulmonary valve closes. This is because the aortic valve is under higher pressure and blood is flowing much quicker through the aortic valve. Now, when you have increased amount of blood in the right heart because of an ASD, the volume of blood on the right side of the heart is now significantly larger. it's going to take a longer time for that blood to be pumped out of the right heart. I hope you're following me. It's going to take a longer time for if you're supposed to have 5 liters of blood, and 5 liters of blood is supposed to be pumped out through your pulmonic vessel. So let's say that this is your right ventricle, and this is your pulmonic artery, for example. And your right ventricle is supposed to pump 5 liters of blood. If it takes 5 seconds to pump 5 liters of blood out, and the aortic valve is going to close before the pulmonic valve, then imagine what's going to happen if we now have 7 liters of blood in the right ventricle because of an ASD, right? If there's 7 liters, it's going to take probably 7 or 8 seconds now to pump 7 liters out of the heart. It means that after the aortic valve closes, it's going to take the pulmonic valve even longer time to close. So there is a width, an increase in the length between the time when the aortic valve closes and the time when the pulmonary valve closes. You see that there is a widening here. Can you see that? There is a widening and there is a clear split. This difference you see here, aortic valve closed, pulmonary valve closed, is very small, very difficult to pick up. Now, when you do this, you widen the gap, and then it's very obvious there is a split in the S2 sound. So you hear this wide difference in the timing, and then you notice that there is a split in the sound. Both of those things put together, they would tell you that a patient with ASD would have a wide, fixed, we'll talk about why it is fixed, split in S2. Patients with ASD will have a wide, fixed split in S2. Why is it fixed? As long as this ASD is here, this pulmonary valve will always take longer to close. So it's going to always be there. If you listen to it, you hear it every single time. So it's a wide, fixed split in S2. That is seen in ASD. So whenever you see it, very important phrase you have to remember. Whenever you hear this phrase, you should think of ASD, right? So we've talked about ASD, we've talked about VSD. Let's talk about another very important part of development that you need to know in childhood. We have an aorta and we have a pulmonic trunk. So if I pick up an image of the heart here, let's use this one. If we use this image, for example, we use this image as the image of the heart. Let's use this for illustration. We'll use it for something else much later. Right here is your pulmonic trunk. This blue guy. It carries deoxygenated blood, which is blue, right? And right here is your aorta. The pulmonic trunk and the aorta both developed from a common origin. So when this child was in the womb and all this development stuff was going on, the ventricles were forming. Let's just represent the ventricles. There was a large trunk, a large blood vessel that was present in embryonic life, a large blood vessel, one big blood vessel. It's going to become the aorta and the pulmonary artery later in life. This vessel was called truncus arteriosus, like a big trunk that is going to form the arteries, the big arteries, truncus arteriosus. Now, what happened? There needs to be a division of this truncus arteriosus. If you're going to have a pulmonary artery and an aorta, you're going to need to divide it into two, obviously, right? So we'll begin to put something in the middle. And what did we call anything that divides something else? A septum, right? A septum that separates the aorta from the pulmonary trunk. It's like aorta, pulmonary trunk, septum separating both of them is going to be called an aortico-pulmonary septum. So this septum that is going to form here is the aortico-pulmonary septum. I'll be talking to you about how you can use nomenclature to actually differentiate or figure out what pathology is all about. The names of diseases many times give you all you need to know about that disease. So the aorticopulmonary septum is a septum that separates the aorta, aortico, from the pulmonary artery, pulmonary trunk. So what did we say pathology is? Pathology is when something normal does not happen, right? Or when something normal happens the way it's not supposed to happen or falsely. That's what we called pathology, right? That's how we come up with pathology. So if we are supposed to form an aorticopulmonary septum, what if we don't form that septum? Then we have a problem, right? Then we have a problem. It means that we'll be stuck. Instead of forming an aorticopulmonary septum, now we are stuck without a septum. We just have this large trunk. Now that is not large enough for my trunk. We have this huge trunk, truncus arteriosus, right? It persists. So the child, instead of being born with an aorta and a pulmonary artery, is now going to be born with one large trunk. We call that persistent truncus arteriosus. So the truncus arteriosus did not go away. It did not become an aorta and it did not become a pulmonary artery. So we'd call that persistent truncus arteriosus. One big trunk, so we'll call this number 1, for example, right? Persistent large trunk arteriosus. The second thing you need to know is that the truncus arteriosus is supposed to divide relatively evenly. So it's supposed to split somewhat in the middle, right? Let's see if we can change this. It's supposed to split somewhat in the middle, a little evenly, so that the aorta and the pulmonary trunk could be relatively of the same size. So again, what is pathology? What if it does not split evenly? Let us say it's decided to split, maybe usually what happens is it will decide to split in this manner to make the aorta significantly larger than the pulmonary trunk, right? It splits in such a way that the aorta is significantly larger than the pulmonary trunk. Look at that. You end up with a huge aorta and a small pulmonary trunk. We will discuss this particular disease a little later. But this is called pulmonary stenosis. Of course, there's pulmonary stenosis. But before we come to this pulmonary stenosis is eventually going to lead to what we are going to call tetralogy or fallot. And we will see that in one bit, okay? Just give me a second. Let us say that the normal process actually occurred and this trunk was actually divided evenly as it should be. Notice that I have labeled the aorta on the left-hand side, right here. And I've labeled the pulmonary trunk on the right-hand side. But that's not how it's supposed to be. Or should we switch it the other way? This should be our right-hand side and this should be our left-hand side. Sorry. So notice that I've labeled the aorta on the right-hand side and the pulmonary trunk on the left-hand side. But you know your aorta is supposed to come from the left ventricle and your pulmonary trunk is supposed to come from the right ventricle. So how are these labelings making any sense? Why am I putting the aorta on the right-hand side and the pulmonary trunk on the left-hand side? It's because during this development, after you have division of the truncus arteriosus into aorta and pulmonary trunk, there's supposed to be a rotation that occurs. There's supposed to be a rotation that occurs. When that rotation occurs, the aorta will end up on the left and the pulmonary trunk will end up on the right. Do you get that? The aorta will end up on the left and the pulmonary trunk will end up on the right. That rotation is the reason why whenever you look at the image of the heart, look at your aorta. The aorta comes this way and curved like that, right? And then look at the pulmonary trunk. The pulmonary trunk came this way. You look at that. It looks like they crossed over each other. That's because they started this way and did that kind of rotation. Do you get that? That is how the aorta and the pulmonary trunk ended up the way that they ended up. So you now ask, what if that rotation did not occur? Remember, pathology is something normal not happening or not happening the way it's supposed to happen. So what if that rotation does not occur? Then they would remain like that. The aorta would actually now arise from the right ventricle, whereas the pulmonary trunk will arise from the left ventricle. And that is not how it is supposed to be. I will tell you why that is the case. Usually, your heart, let's use this guy. The heart is supposed to pump blood. It's a closed system. We'll talk about the closed system in a bit. But your left atrium pumping blood into the aorta goes to the rest of the body. Okay? So the blood leaves, let's use a square box, so maybe it will be easier for you to understand. Blood leaves your left ventricle into the aorta, goes round to your body, supplies all your tissues, and then comes back into the right side of the heart. That's how it's supposed to be. On the flip side, blood leaves your right ventricle into the pulmonic valve, goes to the lungs, gets oxygenated, and comes back to the left ventricle. So look at how this pattern and this system works perfectly. Blood is leaving your right ventricle, going to the lungs to get oxygenated, and then coming back to the left atrium and eventually to the left ventricle. And then your left ventricle pumps that blood to the rest of the body through the aorta, and then it goes all around, comes back to the right atrium and eventually to the right ventricle. And that's how this circulatory system works. Now, if we reverse that process and this rotation does not occur, so we ended up with a right ventricle pumping blood into the aorta and a left ventricle pumping blood into the pulmonic trunk, what is going to be the result of that? That's what we are going to look at right now. Imagine that your right ventricle is pumping blood. The left ventricle, right ventricle. The right ventricle is pumping blood into the aorta. Remember, it's still going to flow to the rest of the body, but it's going to flow back to the right. So this will be the right atrium. Can you imagine that? The right ventricle is pumping blood to the rest of the body, and the blood is coming back right to the right ventricle. Imagine where your left ventricle is pumping blood into the pulmonary artery, to the lungs. And then from the lungs, it's coming back to the left atrium and into the left part of the heart. So we now have two completely separate hearts. This one is pumping to the body and bringing it back to itself. This guy is pumping to the lungs and bringing it back to itself. This guy is going to have oxygenated blood, of course. The left is going to be oxygenated, but it should just be circling from the lungs to the heart, from the lungs to the heart. The right ventricle will have deoxygenated blood. It will be pumping deoxygenated blood round and round and round and round the body. It means that there will be no oxygen going to the tissues. There will be no oxygen going to the tissues. Whenever there is failure of rotation of this trunk to place the aorta where it's supposed to be, the aorta now comes out from the wrong side and the pulmonary trunk comes off the wrong side. We call that transposition of great vessels. Transposition of great vessels. Notice that in transposition of great vessels, there is going to be no oxygen going to the tissues, right? In transposition of great vessels, there will be no oxygen going to the tissues. So what do you think this baby is going to look like? This child is going to appear cyanotic. This child is going to be blue. He's going to be blue as he is born. Almost immediately he's born, you could see that he will change to blue because there is literally no oxygen at all going to his tissues. Imagine a child born with persistent truncus arteriosus. Imagine a child born with persistent truncus arteriosus. We said there is no division between the aorta and the pulmonic trunk. When blood is pumped from the right and left ventricle, it all flows into one large trunk. There'll be a mixture of oxygenated and deoxygenated blood at all times. Again, that child will present with cyanosis. The child will be cyanotic. Then let's look at the third part we're going to talk about. We'll call this disease number 2, because transposition of great vessels, 2 vessels. aorta and pulmonic. Those are the two great vessels. Then finally, we'll talk about pulmonic stenosis. What happens in pulmonic stenosis and why is it important, right? Why is it important that you know tetralogy of fallot as a result of pulmonic stenosis? So we use the analogy initially that what if this truncus arteriosus, if you remember, it was supposed to, we started with a large trunk where we said this was the pulmonic side and this was the aortic side. And we said, what if it did not divide evenly? What if it came to divide somewhere here? Look at that. The pulmonic trunk is now significantly smaller than the aorta. The aorta is so wide. The pulmonary part is so small. Look at this. Eventually, it's going to rotate, right? After dividing, it's supposed to rotate. So when it rotates, this pulmonic trunk will end up on the right. Now you are going to have your right ventricle pumping blood through that very small pulmonic trunk. So let's do this again. The right ventricle will be pumping its blood through a very narrow pulmonic trunk, whereas your left ventricle will have this huge aorta coming off of it. If you blow wind through a very small pipe versus through a huge pipe, what's the difference? Which one is easier to do? If I give you a huge pipe like this and I say blow through it, you can blow into it with your whole head and the air just goes. And then if I give you a straw and I ask you to blow through it, you can tell very easily that it's going to be much more difficult to blow through this very tiny opening than to blow through this huge opening. So imagine what the right ventricle will be going through when it's going to have to pump all this blood through this very small opening versus the left ventricle pumping through a very large opening. The right ventricle is going to be doing much more work. There'll be increased pressure within the right ventricle. And what did we say happens when there is increased pressure within the right ventricle? When you have increased pressure within your right ventricle, the right ventricle begins to grow big. I hope you are answering my questions, even if I can't hear you guys where you are. The right ventricle is going to grow thicker. So what do we have? A right ventricular hypertrophy. We started off with a pulmonic stenosis, remember? That was the primary problem, a pulmonic stenosis. And now we have a right ventricular hypertrophy. Do you see that? The aorticopulmonary septum, if you notice, is right in the middle here. This is the aorticopulmonary septum. It's in line. Let's take back to somewhere. It's in line with our endocardial cushion. So if I was to draw that truncus arteriosus on this previous diagram we already had, it would look something like this, right? That would be your truncus arteriosus. So if you notice very closely, you will see that your aorticopulmonary septum actually forms as part of your endocardial cushion. It forms as part of your endocardial cushion. In fact, they all share a similar origin. Your aorticopulmonary septum and endocardial cushion are neural crest derivatives, meaning that they arose from your neural crest cells. So you can imagine that if there is deviation of your aorticopulmonary septum, if it does not develop where it's supposed to develop, or if it's pushed too much to one side, your endocardial cushion is probably pushed to one side as well. So what that also means is that the membranous portion, remember, even if this was our endocardial cushion, that's where it's supposed to be. It's supposed to form the membranous portion of this ventricle. But we now have this aorticopulmonary septum pushed to the side. Do you see what has happened here? There's an opening here. When we have the rotation and we come to this picture, the membranous portion of your interventricular septum is supposed to form here. The endocardial cushion is supposed to be somewhere here. What you notice is that there is opening around this point. Usually, in people that have this condition, if there's a defect with the aorticopulmonary septum, they are more likely to also have a defect with the membranous portion of the interventricular septum. If there's a defect with the membranous portion of the interventricular septum, now this patient also has a VSD. So now we also have a VSD. This patient also has a VSD. Now, if you look closely at this image, you would see that the aorta, which is this guy, actually sits from here. look at this closely, all the way to this end. It's covering the left ventricle, of course, and it's also covering our VSD. Look at the VSD. The aorta rather is covering, is sitting over your VSD. We call this an overriding aorta. So let's recap for 1 second. We started with pulmonic stenosis. That was the primary problem number 1. As a result of the pulmonic stenosis, this patient developed a right ventricular hypertrophy, problem number 2. Because the cardiac pushing is going to be displaced if the aortic pulmonary septum is also displaced, we developed a VSD, problem number 3. Now we see that the very huge aorta is also covering the VSD, a problem number 4. We call that an overriding aorta. We have 4 pathologies born out of 1 error: pulmonic stenosis, inability for or failure of the aorticopulmonic septum to be divided evenly. This disease is therefore called tetralogy. 4 or fallot. This disease is therefore called tetralogy of fallot. Again, if we have a VSD, a pulmonic stenosis, you're going to notice that blood is going to mix very easily. When the right ventricle contracts, there's a wide VSD over here. You are going to have deoxygenated blood mixing with oxygenated blood. This child is going to present with cyanosis. This is the most common of these diseases, and you want to know it because it's also the most commonly tested on your exam, right? You have tetralogy of fallot. So what are the components, the 4 components of tetralogy of fallot? We started with a pulmonic stenosis. We had a right ventricular hypertrophy. We had a VSD, and we had an overriding aorta. Those are the 4 components of tetralogy of fallot. I hope everybody is following up to this point. Tetralogy of fallot is also one of the early cyanotic diseases. It's one of the early cyanotic diseases. Now, how are these children going to present? Primarily, you already know they'll be cyanotic. They'll present with cyanosis. The second thing you know already is that when these children begin to exercise, especially when they exercise, that is when their tissues need more blood. So when a child is always going to play, when the child runs from here to that end and back, his muscles would be crying for more and more oxygen. So that is when the child is going to feel the what do we call it? Whenever your muscles are not receiving enough oxygen, you feel pain or you feel fatigued. The child is going to be exhausted, and then they're going to want to squat to try and get a rest. Okay, some of these children are going to be crying very loudly because of the pain they're going to be feeling, and we call those episodes text spells. There are just going to be periods when the child is going to cry. And then one other thing is, as they play and they get exhausted, they will squat for relief, right? Squatting provides relief, and we'll talk about why squatting provides relief. Whenever the child squats, you actually increase blood flow back to the heart, right? The amount of blood flowing back to the heart increases. You increase venous return. We'll talk about all these definitions eventually. You increase venous return when you squat, because when you squat, you squeeze the muscles of your lower limb, and those muscles squeeze on the veins of the lower limb, and blood is pushed back to the heart. If blood is pushed back to the heart, there will be increased pressure in the right ventricle. The right ventricle will pump a little more blood through the stenosed pulmonary artery, and that blood goes to the lungs. There's a little more oxygenated blood available, and the child gets a little better. So what are you looking for when you're picking a diagnosis of tetralogy of fallot? It's very common. You're looking for cyanosis, you're looking for text spells or crying episodes. You're looking for squatting to get relief. All of these are going to be components that would make up your tetralogy of fallot, right? So you want to bear all of those things in mind. We've talked about VSD, we've seen ASD, we've seen patent ductus arteriosus, we've seen Eisenmenger syndrome, we've seen thrombus arteriosus, transposition of great vessels, and tetralogy of fallot. There are other early cyanotic diseases, but I have not gone into them because they are not very important for your exam, right? So if you look at your first aid, you're going to see TAPVR, right? Again, not important, not important. TAPVR is total anomalous pulmonary venous return. You are very unlikely to have a question on it, so we wouldn't bother wasting our time on that guy. The next thing we want to know is a little blood supply to the heart. How does the heart receive blood? You want to know that your heart first is supplied in diastole. The heart is supplied in diastole. So when the heart is contracting, it does not receive blood. It gives blood to other parts of the body. When the heart is relaxing, it receives blood for itself. Why? Your coronary arteries, if you can see this image, come off the heart at this point. When the heart is contracting, it is at high pressure. The blood is flowing very quickly out of the aorta. The blood is flowing very quickly out of the aorta, very quickly out of the pulmonate or pulmonary artery. That high pressure blood cannot suddenly curve. Think of it. Cannot just turn and then start going into your coronary artery. That does not happen. No, that's not expected to happen. So when the heart contracts and blood moves out, when the heart begins to relax, as it begins to relax in diastole, some of this blood actually flow backwards. When they flow backwards, they flow into the coronary arteries and supply blood to the heart. So one thing you want to know is that the heart is supplied in diastole. The heart is supplied in diastole. I hope everybody got that information clear. Great. The heart is supplied in diastole. The blood vessel to the heart is the coronary artery. And there are two of them, the right coronary artery and the left coronary artery. If you look closely here, you'll see the left coronary artery. The left coronary artery. When the left coronary artery comes out, please, it's important that you know the steps each of these blood vessels take. That's an important question on the exam. So we start with the left coronary artery. The left coronary artery gives a branch we call the circumflex artery. And it's the only circumflex artery. Sometimes they'll write it as left circumflex, LCA. So whenever they say circumflex artery on your exam or anywhere, you know that talking about the left circumflex artery. There's no right circumflex artery. So the circumflex artery is always on the left. It also gives rise to the left anterior descending artery. This one right here. The left anterior descending artery. You'll notice that the left anterior descending artery is supplying the inferior-ish area of the heart. Right? Don't worry about the diagonal branch, not important. The circumflex branch you probably want to know. Now, on the right side, before we go to the right side, rather, the left coronary artery is supplying the left ventricle, obviously, right? The left circumflex is going to supply the left ventricle. The left anterior descending is actually supplying the inferior part of the heart and part of the right ventricle, but we'll look at all those later. The right coronary artery, on the other hand, look at it, come out there. It is just right coronary artery. There's no right circumflex. It gives rise to a marginal branch. Is that important? No, you don't have to remember that either. And then this marginal branch, however, rotates and supplies the side. Don't worry about that. We have a branch that goes behind, and this is the branch I'm most interested in for your exam. The branch that goes behind and supplies the posterior part of the heart. That blood vessel is called the posterior interventricular artery. It is also called posterior descending artery. PDA, the posterior descending artery. You have to know this blood vessel because it's very important. Let's look at other structures in the heart. If you remember, in your heart, we have the SA node, we have the AV node. The SA node is located somewhere around the top of the left ventricle, of the right ventricle rather, somewhere here. That's where you have your SA node. The AV node is located somewhere close to the middle between the right ventricle and the right atrium, or between the right ventricle and the left ventricle, the boundary where you have the atrium to ventricle, right? We'll talk about that guy and we'll draw it a little better later. That's how they are located. The right coronary artery, 100% of the time, supplies the SA node. All the time. The blood supply of the SA node is the right coronary artery. The AV node is a little different. Most of the time, in about 80% of people, the AV node is supplied by the right coronary artery. So if you're at med school, you may have also memorized that, oh, the right coronary artery supplies both the SA node and the AV node. That's usually because actually in 80% of people, the right coronary artery supplies the AV node. But what we're about to learn is going to show us difference, and that is a concept that they'll test on your exam. So you have to know this. Good. The posterior descending artery, we said, arises from the right coronary artery. The actual part of the right coronary artery that supplies the AV node is the posterior descending artery. So the right coronary artery gives rise to the posterior descending artery, and the posterior descending artery supplies blood to the AV node. We'll see why this is important. We talk about the concept of dominance. Dominance. What is dominance? Simply put, dominance is simply the blood vessel where the posterior descending artery arises from, the origin of the posterior descending artery. That is what dominance is all about. So if the posterior descending artery arises from the right coronary artery, if it arises from the right coronary artery, how am I typing? Writing. If it arises from the right coronary artery, we would say that this person has right dominance. If the posterior descending artery arises from the right coronary artery, we would say that this person has right dominance. If it arises from the left circumflex artery, now notice I didn't say left coronary, left circumflex artery. But you have to also remember that the left circumflex artery obviously is a branch of the left coronary, so both of them could go. Then we would say that this person has left dominance. Right dominance is in 80% of people. Left dominance is in, let's say, 15% of people. And then we have people that actually have two posterior descending arteries, right? But we don't really care about that for your exam. Great. So right dominance, left dominance. What does this mean for you on your exam? And why are we even bothering to go through this information? If someone has left dominance, it means that the left circumflex artery gives rise to the posterior descending artery. Look what we saw here. We had said previously that the posterior descending artery is what actually supplies the AV node. So because the right coronary artery gave rise to the posterior descending artery, it means that the right coronary artery supplies the AV node. But what if the left circumflex artery is giving rise to the posterior descending artery? The posterior descending artery will still supply the AV node. And what that means in this situation is that actually the left circumflex artery is supplying the AV node. So what do you need to remember from here? In persons with left dominance, the left circumflex artery supplies the AV node. In persons with left dominance, the left circumflex artery supplies the AV node. The way they would ask you this question is in this manner. They'll tell you that 45-year-old woman was involved in a motor vehicle accident and whatever, she had an injury to the heart. They'll describe something. And then they'll ask you to, they'll tell you she has left dominance, that on examination, they found that she had left dominance. They'll ask you to describe the blood supply. So they would put something like left coronary artery, left circumflex artery, posterior descending artery, or interventricular artery, posterior interventricular artery, something like that, AV node. Then they'll put other options, right? Circumflex, something like that. So they want you to know what dominance means. Dominance simply means where does the posterior descending artery originate from? And if it originates from the right coronary artery, that would be right dominance. If it originates from the left circumflex artery, that would be left dominance. I hope everybody understands that part. The next thing we want to look at, we want to go closer into the heart and actually look into some structural abnormalities. We had said that when you look at the heart, in the heart, you're supposed to have certain structures like valves, right? We call them valves. So if this is the heart over here, we have our left ventricle, we have our left, the membranous portion, you remember that. We have the left atrium. We are more concerned with the left part of the heart, okay, because that's the part they focus on your exam, not really the right part. Here we have a valve. Do you guys remember what this valve was? I hope you're thinking the mitral valve. The mitral valve. Now, blood is going to flow from the left atrium into the left ventricle. That is what is supposed to happen. And blood is supposed to flow out of the left ventricle into the aorta. Blood is supposed to flow out of the right ventricle into the left ventricle, rather. Sorry, our diagram is not very accurate. Into the aorta, rather. All right. Here, we have the aortic valve. Important. Please bear this in mind. We have the aortic valve. So this right here is our aortic valve. This right here is the mitral valve. During diastole, the aortic valve is supposed to be shut and the mitral valve opens. So in diastole, the heart is filled with blood. In diastole, the heart is filled with blood. Blood flows from the left atrium into the left ventricle across the mitral valve. What did we say pathology is? Well, something that's supposed to happen, not happening, or not happening the way it should happen. So if blood is supposed to flow from the left atrium into the left ventricle, what if that does not happen? The question becomes, why will that not happen? Perhaps because the mitral valve is too stiff. Remember that this valve is supposed to close. So if this is the valve is supposed to close, and then when it's time for blood to flow through it, it's supposed to actually open up. So what if that does not happen? The valve is not allowing blood flow through it. We are going to call that mitral valve stenosis. Mitral valve stenosis. Stenosis means something is narrowed, something is smaller than it should be, something is thin, right? That would be mitral valve stenosis. What is going to happen if someone has mitral valve stenosis? This left atrium will be pushing so hard to try to open that mitral valve. The left atrium will be pushing so hard to try to get the mitral valve to open. If the left atrium is pushing so hard to try to get the mitral valve to open, what happens to the left atrium? It's working with more pressure, trying to open a stiff valve, trying to push open a stiff mitral valve. So the left atrium begins to undergo hypertrophy. The left atrium begins to undergo hypertrophy. The walls of the left atrium begin to thicken. Remember what happened to our right ventricle we talked about? When the right ventricle was working with a lot of force, the right ventricle began to enlarge. We call that right ventricular hypertrophy. Now we are having atrial hypertrophy. The atrium begins to grow bigger. There are consequences to that, and we would come to those in just 1 minute. After a lot of pressure is put on this mitral valve, eventually the valve is going to open, but many times the valve is not going to open easily without a sound. I told you whenever there's an abnormality with any part of the cardiovascular system, many times we are going to hear a murmur. So that mitral valve usually will open forcefully, like make a snap, right? It will open forcefully. Like what happens when you push on something is difficult and then it suddenly opens. So people with mitral valve stenosis will usually present with an opening snap. So there's pressure on it until it snaps open. That is what happens in mitral valve stenosis. What else do you need to bear in mind? This murmur is occurring in diastole. So the murmur of mitral valve stenosis is a diastolic murmur. It's a diastolic murmur. Very important. You hear an opening snap. Depending on how stiff the valve is, depending on how stiff the mitral valve is, it will take longer or shorter time before you hear the opening snap. If the valve is not very stiff, we push it for a bit, it snaps open. If the valve is very stiff, we push it for a longer time before the opening snap. So the duration of time until the opening snap is what determines the prognosis. If it takes a short time before you hear the opening snap, it's probably not that bad. If it takes a very long time before we have the opening snap, then you know that, okay, this is a very severe condition. So the duration of time from when there is diastole, from the beginning of diastole, until when we hear the opening snap is what tells us how severe or how mild the disease is, right? That's what we call the prognosis. Great. You want to remember that. Now let's look at the consequences of mitral valve stenosis. The left atrium begins to grow bigger. Look at this. It's now bigger than usual. If you remember, in the cardiac cavity, in the heart, or in the chest cavity where you have your heart, if we look at one of the images of the heart that we put here, good, this is what we have, right? The left atrium is actually on the posterior part, and that's some important anatomy. I think I didn't mention that to you before. You want to know that the left atrium forms the posterior border of the heart. The posterior part, it's on the back. The heart is sitting in the chest cavity like this, facing the left side. The left atrium is posterior most. It forms the posterior border. The right atrium forms, the right ventricle rather. The right ventricle forms the anterior portion of the heart. So what you are seeing right here is the right ventricle. Sometimes they'll ask you a question. If they drive a knife into a person's chest in front at about the 4th intercostal space, what structure will be damaged? The structure that is facing you when you are facing a human being is actually the right ventricle. You want to know that. That's an anatomy question from the heart. So the right ventricle forms the anterior part of the heart. The right atrium forms the lateral border, the right border. The right lateral border of the heart. So you see right here, this is the right atrium, right? That is the right atrium. It forms the right, on the right lateral border of the heart. That's important that you know. The left ventricle forms the left border. Forms the left border of the heart. I hope everybody follows to this point. So what you want to know is that because the left atrium is on the posterior most part of the heart, because the left atrium is on the posterior most part of the heart, when it begins to grow large, it's going to begin to compress the structures around it. It's going to begin to compress the structures around it. So if we have the heart like this, the way it is in the cavity, the left atrium is somewhere here. Behind the left atrium, we actually have structures like the esophagus. The esophagus is descending and passing behind the left atrium in the retroperitoneal cavity. Don't worry about that. It's passing behind the left atrium. That's all you want to know. The esophagus passes behind the left atrium. And this is important anatomical association you want to make. Whenever we want to look at the atrium, one of the things we do is transesophageal echocardiography. We put the scope through the esophagus and we pass it until we reach the posterior aspect of the left atrium, and then we look into the left atrium. Why? Because the esophagus is directly behind the left atrium. You want to know that. That's an anatomy question. You see it when you start practicing questions. The other way we can look at the heart is by doing transthoracic echocardiography. Basically, instead of going through the esophagus, we go through the thorax, right? Through the trachea, for example, through the trachea. We go through the trachea and we pass the scope down. Again, these two structures are very close behind the left atrium. What that means is that when the left atrium begins to undergo enlargement, it begins to compress these structures. The left atrium undergoes enlargement and compresses your esophagus, for example. Think of that for a moment. If the left atrium is large and it begins to compress the esophagus, what happens? This person is going to have difficulty swallowing. What do we call that? Dysphagia, right? We would call that dysphagia. Now, if you're having a dysphagia because of a pathology of the heart, if you're having dysphagia because of pathology of the heart, so the heart is what is actually causing the dysphagia. The large left atrium is what is causing the dysphagia. We call that dysphagia cardiac dysphagia. If you are having dysphagia because of a cardiac pathology, we call that dysphagia cardiac dysphagia. I hope everybody gets that. Nomenclature is everything to pathology and actually to your basic medical science as a whole. So we'd call that cardiac dysphagia. That is one thing you're going to see, and it's because of the left atrium compressing the esophagus. The second thing that can happen is that the left atrium could compress your recurrent laryngeal nerve. Okay, the recurrent laryngeal nerve. The recurrent laryngeal nerve is one of those nerves that wounds around the aorta and is responsible for vocal cord activity, right? So whenever you damage the recurrent laryngeal nerve, you're going to hear abnormality in the voice of the person, like hoarseness of the voice. So imagine that your atrium grows large and compresses the recurrent laryngeal nerve. These patients may present with hoarseness. Hoarseness of the voice. And this is as a result of compression of the recurrent laryngeal nerve. This syndrome is usually called Ottner's syndrome, but you don't have to remember Ottner's syndrome. Nobody will ask you about Ottner on your exam. Do you guys get it so far? Great. All right. Those are some of the pathologies that you can have in persons presenting with enlarged atrium as a result of mitral stenosis. Another thing that will happen is that you're stretching the neural connection of the heart, right? So there are nerves that supply the atrium that are running around the atrium. As the left atrium starts growing larger and larger, you stretch out all those nerves. And when you stretch those nerves, you mess up the electrical connection of the heart and you increase the risk for what? Atrial arrhythmias. You increase the risk for atrial arrhythmias. So arrhythmias can occur, cardiac dysphagia can occur, hoarseness of the voice can occur because of mitral valve stenosis. Remember that with mitral valve stenosis, you hear an opening snap. It is a diastolic murmur. All of those information are very important. The duration until the opening snap gives us the prognosis that we are looking for. All right. Now, that is one valve, the mitral valve. The next valve we are going to be talking about, anything that I talk about on the left heart, just picture the same thing on the right, okay? So if there's mitral stenosis, on the right, we have tricuspid valve over here, tricuspid stenosis. So both mitral stenosis and tricuspid stenosis are going to be diastolic murmurs. We are going to ask, what causes mitral stenosis? Do we just sleep and wake up and develop mitral valve stenosis, right? What are the risk factors for people developing mitral valve stenosis? Rheumatic heart disease is number one. And it's about the only one you need to know. We'll talk a little more about rheumatic heart disease down the line, right? But again, you're not supposed to just read something and then read something else. The goal of the USMLE and your ability to pass the USMLE depends on how efficiently you can make the connection between all of these things at the same time, right? So rheumatic heart disease is the primary cause of mitral valve stenosis. If you remember anything about rheumatic heart disease, you will remember that these people had strep pyogenes infection, maybe they had a sore throat before, and then perhaps it wasn't treated properly, and then there's molecular mimicry. The body sees strep and thinks, oh, this strep looks familiar. Like maybe the body sees strep and attacks strep first of all, and then it looks at your heart. I say, but this heart looks like strep. And then the body attacks the heart as well. That's what happens in rheumatic heart disease. The body attacks strep pyogenes, tries to fight streps, makes antibodies against strep, and then it looks at the heart and it sees this thing on the heart called M protein. And it says, the heart looks like strep, and then attacks the heart as well. That is rheumatic heart disease. They usually first develop mitral regurgitation, and then this mitral regurgitation can progress to become mitral stenosis, right? I think that is clear. So rheumatic heart disease is a major cause you want to remember. The second pathology we want to think about is going to be mitral regurgitation. During systole, now we've talked about diastole. So during systole, what do we expect to happen? The heart begins to contract. The whole goal of systole is to push blood out of the left ventricle. Let's see. The whole goal of systole is to push blood out of the left ventricle. While that is happening, we expect, of course, your aortic valve to open, but we don't want blood going back into the left atrium, right? So we expect the mitral valve to be shut. The mitral valve is expected to be shut during systole. Only the aortic valve is expected to be open and blood is supposed to flow out through the aorta. Pathology is when what is supposed to happen does not happen. So what if for some reason, because of rheumatic fever, the mitral valve is now weak, or this person had an MI and ruptured their caudate tendinae? We'll talk about that in a bit. And so this mitral valve is not closing properly. It's allowing blood flow through during systole. A valve that allows blood flow through at the wrong time is an inefficient valve, insufficient valve, regurgitant valve. So we would call that mitral regurgitation. It's also called mitral insufficiency. And you want to absolutely remember that. Mitral regurgitation or mitral insufficiency. Usually, because the ventricle is at a very high pressure, the blood is going to flow through the mitral valve throughout systole. So as long as the left ventricle is contracting, you're going to have blood flowing through the mitral valve throughout that time frame, right? So when you listen to the heart of a patient with mitral regurgitation, you're going to hear a murmur throughout systole. So we call that a hollow systolic murmur. We call that a hollow systolic murmur. Systolic murmur head, the whole of the murmur head throughout the whole of systole. Systole is a hollow systolic murmur. I hope you get that clearly. Then the next thing is, where are we going to hear this murmur? You're going to hear this murmur at the fifth intercostal space, mid-clavicular line. Okay, so somebody is going to now ask, how did we come up with all this? How do we know or where we hear the murmur? Do I just have to memorize it? technically you memorize it. It's not that difficult to memorize actually, but you can give a little context to it, a little understanding to it. Valves have reflection points. Valves have reflection points. What that means is this. If you look at this heart, okay, let's just look at a different image for the heart. So let's take, which of them should we use? Let's take this heart, for example. No, not the them. Okay, let's take this heart, for example, okay? Your mitral valve is somewhere, this is the left atrium over here. I don't know how, if you can see clearly. This is the left atrium over here. So blood is going to flow from your left atrium into your left ventricle somewhere there. Now, this blood is flowing in this direction. So if your blood is flowing through your mitral valve, it's going to flow in this direction. So when you listen to the heart, when you listen to somebody's heart, if there is a problem with the mitral valve, you're going to hear that sound at the point of reflection or inflection of the mitral valve, at the end point of the mitral valve. So if the mitral valve is supposed to be passing blood in this direction, we expect to hear the sound here, any sound coming from the mitral valve at that point. So in this scenario, you expect to hear the sound coming from the mitral valve somewhere here. Does that make sense? And this corresponds to the fifth intercostal space, mid-clavicular line. Does everybody get that part? Something like that. We'll talk about the aortic valve in a bit, and we'll see where we actually hear the murmur of your aortic valve. And this is the same thing for the mitral regurgitation and mitral stenosis. So where are they going to tell you they are hearing the murmur if they want to ask you a question on mitral stenosis? Fifth intercostal space. Everything mitral valve. Fifth intercostal space. All right. That is mitral regurgitation. Again, if there's mitral regurgitation, this patient is going to present a murmur. The left atrium is going to grow larger. There will be atrial arrhythmias because more blood is pumping into the atrium than expected. So the atrium is again going to grow enlarged. There will be arrhythmias potentially happening there. And then if blood is going back into the left atrium, it's probably going to go back to the lungs. Sometimes these patients may present with edema, pulmonary edema, at the late stages of their disease. But I think if you know the murmur and you know where you hear the murmur, you are at a good place already to start. That is mitral regurg. The next thing we want to talk about is the aortic valve. We said that during systole, the mitral valve should be shut. And then we looked at what happens if it is not shut. During systole, the aortic valve should open. This is it. The aortic valve should open and blood should be able to flow through the aortic valve to supply the different tissues of the body. Pathology is when what is supposed to happen does not happen. So the question becomes, what if the aortic valve does not open? What did we call that? Stenosis. The aortic valve is stiff. It's not opening. We would call that aortic stenosis. Aortic stenosis. Again, if the aortic valve is stiff, this is how it works. Imagine a river, there's a flood, a tornado or something, and everywhere is flooded. And so people shut all their doors, right? People shut all their doors so that water does not come in. But there is a lot of pressure coming with the water. What happens? The water begins to push against the door. And what happens initially is that a little amount of water begins to seep into some people's doors if your door is not strong enough. And then before you know what's happening, the water topples the door over and a large amount of water flows through the door. And then when the large amount of water has gone through the door, it drains again and comes to a halt, right? So that's the kind of thing that happens when you have a door closed against a large body of water that is trying to destroy everywhere. It pushes against the door. Some amount of water will be passing through gradually. And then eventually the door topples over and we have everything flow and then it comes down again. And that is what happens in aortic stenosis. The ventricle begins to contract the aortic valve is stiff, the ventricle is forcing the valve open, and we have blood going through that valve. And then eventually, boom, it opens up, blood flows out of the heart, and then everything comes back to rest. When you listen to the heart of a person with aortic stenosis, the murmur of aortic stenosis is going to sound like what I just described. You hear the murmur low, 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 and then it gets loud, and then it comes down. We describe that as a crescendo, decrescendo murmur. A crescendo, decrescendo. Crescendo, decrescendo is using music, right? It's going up, it's coming down. Crescendo, decrescendo murmur. So whenever you hear that murmur described, they are talking about aortic stenosis. Who gets aortic stenosis? That's the next question you want to ask, right? Who gets aortic stenosis? This valve is the valve that receives the greatest beating of its lifetime. So the left ventricle is at very high pressure. All that pressure is received by the aortic valve. So you can imagine that the aortic valve is going to undergo a fair amount of wear and tear over a person's lifetime. So by the time a person is 70 years old, imagine that the aortic valve is technically almost dead at that point, right? By the time a person is 70 years old, the aortic valve is literally dead at that point for many people. And this valve becomes calcified. If you remember from your general pathology, if you notice, I will say this now, if you notice on your bootcamp schedule workbook, I did not put general pathology, general pharmacology. So as we are going along, I'm going to be explaining general pathology concepts with everything we are doing. You wouldn't have to even think you're learning general pathology, you just learn general pathology. So, and when you hear me go into some general pathology stuff, follow me. It will be very important, right? So when the aortic valve receives all this wear and tear, calcium begins to deposit on the aortic valve. We call that dystrophic calcification. We call that dystrophic calcification. Deposition of calcium on damaged tissue. Dystrophic calcification. There is another type of calcium deposition that we have. It's called metastatic calcification. Metastatic calcification. Metastatic calcification is simply when there is deposition of calcium on tissues because there is excess calcium in the body. So if you have hypercalcemia, and as a result of hypercalcemia, you're having deposits of calcium in tissues. So dystrophic calcification is deposition of calcium on damaged tissues. Metastatic calcification is deposition of calcium on tissues because there is excess calcium in the blood. Your normal calcium level should be around 8 to 10 milligram per dl. You need to know the normal calcium level. All right, so let's go back to aortic stenosis. We deposit calcium on the aortic valve because the aortic valve is damaged, because it's receiving a lot of wear and tear. So it's actually what? Dystrophic calcification. They'll give you a vignette and they'll give you someone with aortic stenosis, and they'll ask you the process involved in creating that stenosed valve. It's going to be dystrophic calcification. And then we end up with a stenosed valve. We hear a crescendo, decrescendo murmur. There's a second reason why people may develop aortic stenosis. The second reason is going to be because of rheumatic heart disease. Okay, someone is already wondering, but you said rheumatic heart disease caused mitral valve stenosis and mitral regurgitation, perhaps. Why are you putting it under aortic stenosis? Well, rheumatic heart disease causes all of them, right? The most commonly affected valve by rheumatic heart disease is going to be the mitral valve, okay? The most commonly affected valve is going to be the mitral valve. So maybe we should put it somewhere here. And this is a question on the exam as well. When people have rheumatic heart disease, the mitral valve is the most commonly affected, much more than the aortic valve, but the aortic valve is the close second. And you want to remember that in each of these cases, usually we begin with regurgitation. So whenever rheumatic heart disease destroys the aortic or the mitral valve, you start with aortic regurgitation or mitral regurgitation. But again, because we have a damaged valve, calcium is going to do what calcium is going to do. We have dystrophic calcification, and we eventually develop stenosis, right? So we go from mitral regurgitation to mitral stenosis. We go from aortic regurgitation to aortic stenosis. I hope that makes sense. The second reason people are going to have aortic stenosis, which is the major reason and the biggest one on your exam, is because of aging, right? So dystrophic calcification as people increase in age. So if we are old, your valve is old, and it is what it is, right? All right, so typical vignette for aortic stenosis on your exam. 70-year-old man. Yes. Presents with syncope. 70-year-old man presents with syncope. Right there, you know they're talking about aortic stenosis. That's the most likely thing that question will be asking about. When you get access to your test-taking mastery strategies, I'm going to show you how you use just the first line of questions to answer questions correctly. Okay, so they give you a 70-year-old man that's presenting with syncope. Immediately you read that line, you know, all right, this is an aortic stenosis question. Okay, why do they have syncope? Syncope is like fainting, but they're not quite the same. They are different causes. Now, when the heart is trying to contract, the aorta is stiff. That's time you need blood going to your tissues. Imagine your brain, you need blood flowing to your brain. If someone has severe aortic stenosis, they may go throughout systole and very little blood will be pumped out of the aorta. What that means is that for a long time, their brain will be without blood. If your brain is without blood for a very long period of time, what's going to happen? You're going to pass out. So these people pass out. The more severe their aortic stenosis, the more recurrent episodes of syncope these patients are going to have. So that is aortic stenosis. That's the typical presentation. Sometimes they may give you a child that was born with aortic stenosis. That's more common on step 2CK than on step 1. But you want to know that in case they give you a vignette that looks like a child, but actually it sounds like aortic stenosis, you are sure it's aortic stenosis. But then the child is young, it's in a 4-year-old. How can it be aortic stenosis? Go ahead and pick aortic stenosis, okay? That is actually congenital aortic stenosis. It's not common in step 1. The last reason people develop aortic stenosis is going to be bicuspid aortic valve. People with bicuspid aortic valve. The aortic valve is tricuspid. You have a valve like this, like this. It has 3 cusps, 1, 2, 3. But there are persons that are born with aortic valve that have just 2 cusps. This is the normal aortic valve. This is a bicuspid aortic valve. This bicuspid aortic valve is more likely to undergo wear and tear much faster as well than the regular aortic valve. So people with bicuspid aortic valve, they will give you a 50-year-old man with aortic stenosis. A 50-year-old man with aortic stenosis. What comes to mind? Bicuspid aortic valve. Do you get it? 50-year-old man with aortic stenosis, you think he probably had a bicuspid aortic valve. That is also important and something you want to know. We've looked at aortic stenosis. The final murmur we are going to consider today is going to be aortic regurgitation. What is aortic regurgitation? When blood flows out of the heart, I told you before, if this is the left ventricle, blood is supposed to flow through the aorta, out of the left ventricle into the aorta through this aortic valve. When the blood flows out, a fair bit of blood, a fair amount of blood is supposed to flow back into the heart. It's supposed to flow back towards the heart. It's not supposed to go into the heart. It's supposed to flow back towards the heart during diastole. But when that blood tries to flow back, when the blood tries to flow back, the aortic valve is supposed to have closed. It's supposed to hit a closed aortic valve. Some of this blood will now go into your coronary artery. That's what we said. That's what we mean when we said the heart is supplied in diastole. So during diastole, the beginning of diastole especially, a fair bit of blood will try to flow back into the heart. But the valve is supposed to be closed already, and then this blood will go into your coronary arteries and supply the heart. But what happens if the valve is not closed? Again, because rheumatic heart disease or rheumatic fever have damaged this valve, what's going to happen? Then we have a regurgitant aortic valve. We have an aortic valve that is insufficient. We have aortic valve that is insufficient. This is what we call aortic regurgitation or aortic insufficiency. What will cause it? Again, rheumatic heart disease. Rheumatic heart disease will be a major cause of aortic regurgitation or aortic insufficiency. You want to bear that in mind. Very important. There are other causes if people have myocardial infarction, MI, that resulted in rupture of chordae tendineae. But don't worry about that. We'll talk about it when we do MI. We'll treat this in more detail when we get to that part. All right. So remember these things that we've done so far. Now we are going to talk about mitral valve prolapse. I should have mentioned mitral valve prolapse when we talked about mitral regurgitation, but let's just talk about it briefly. Aortic regurgitation, you need to remember, it's a diastolic moment. Okay, it's a diastolic moment. We'll do more of these guys eventually. The next part you want to know is mitral valve prolapse. Very important. There are a lot of persons in the population that have mitral valve prolapse that would never know because it's asymptomatic for most people. It's just there, especially women. A lot of women have mitral valve prolapse, but it's asymptomatic. We would never know unless it becomes symptomatic or problematic, right? That's mitral valve prolapse. What happens in mitral valve prolapse? There is ballooning. There is ballooning of the mitral valve into the left atrium. Ballooning of the mitral valve into the left atrium. We talked about mitral insufficiency, where we had said during systole, the aortic valve should be open, the mitral valve should be closed. So if we put the mitral valve here, the mitral valve should be closed. But as blood is flowing through this aortic valve, there will be a lot of pressure put on the mitral valve as well. What happens in mitral valve prolapse is that there's weakening of the valve. So if this is the valve, for example, in the medial part of this valve, somewhere here, there is tissue, right? Tissue. There is tissue here. And that tissue is damaged, what we call myxomatous degeneration. So we are going to have this, it's like fluid, you have particles, right? Fluid is soft, dissolved, like jellies inside your mitral valve, right? Think of jellies in your mitral valve. The mitral valve is now flexible, flappy. It's not as strong as it's supposed to be. We call that myxomatous degeneration. You can think of it as depositing some form of fibers and some form of glycosaminoglycans. I don't want to go into all of those because they're not important, but that's the technical way to describe it. It doesn't matter. What is important is that there is myxomatous degeneration. This is the phrase I want you to remember. Myxomatous degeneration of the mitral valve. If you have myxomatous degeneration of the mitral valve, the mitral valve becomes more flexible than it's supposed to be. So when there is pressure put on the mitral valve during systole, there will be ballooning. The mitral valve is just going to fly upwards into the left atrium. It's like, oh, it's bent like that, right? So it bends, this valve bends like that into the atrium. You see that? It bends into the atrium. We call that the ballooning of the mitral valve. Now, the valve is not particularly opening up. It's not opening up easily for blood to flow through it. It's as if it's trying to resist. So it does that. It balloons. There's ballooning of the mitral valve into the left atrium. What patients get mitral valve prolapse? It's more common among people with Marfan syndrome. It's more common among people with Marfan syndrome. You see myxomatous degeneration. We are going to be talking about Marfan syndrome a little more related to the heart in a bit, right? If you stretch your valve like that, if there's ballooning of the mitral valve, imagine that the valve is not going to hold as tightly as it's supposed to be, right? Imagine that it's supposed to be this tight, and then there's ballooning, something is forcing it. There'll be some lapses in contact, right? The valve is no more going to do exactly what it's supposed to do because it's under a lot of stress. So there may be a bit of regurgitation. So usually when there's mitral valve prolapse, you also have mitral regurgitation accompanying the prolapse, right? So when there's mitral valve prolapse, there's often mitral regurgitation accompanying the prolapse. So you may hear a murmur of prolapse, a prolapsing kind of murmur, a regurgitant murmur along with the mitral valve. Does everybody get everything we've done to this point? If you have any confusions, remember you should type your questions so that I can always go back to explain. But then again, you can always watch the video multiple times and you get what it is we are talking about. That's mitral valve prolapse. Okay, let's define some very simple things related to the heart, because once we start talking about key pathologies, I'm going to start using some terminologies that a lot of you may not understand very quickly. So if you look at your roadmap, I had put a section for definitions, right? So that when we start using terms, you're going to easily follow along. We have things like cardiac output. Cardiac output is simply the amount of blood that is released from the heart in one cycle, in systole. So if your heart contracts, that is, blood is going to be pumped out, right? When your heart contracts for 1 minute, then we can calculate your cardiac output. When the heart contracts for a minute, so the cardiac output is the volume of blood released from the heart in 1 minute. So how can I know how much blood is released in your heart in 1 minute? I need to know how much blood is released each time your heart contracts, right? Each time your heart contracts, the blood released is the stroke volume. I want you to make the distinction between these things clearly now because it's going to be helpful. When your heart contracts 1 time, the blood released is the stroke volume. So if I know the stroke volume, and then I know how many times your heart contracted in 1 minute, that is going to tell me how much blood. I just need to multiply. So if Candice's heart pumped let's say 5 liters of blood each time it's contracted, and if it actually beats 70 times in 1 minute, that means 5 times 70 will tell us the total amount of blood that was pumped out of Candice's heart in 1 minute. That would be your cardiac output. So to calculate cardiac output, we take your stroke volume, the amount of blood pumped in your heart per beat, and we multiply it by the number of times the heart beats, which is the heart rate. Stroke volume times heart rate will give us the cardiac output. For your exam, formulas and memorizing formulas is not what we want to attempt to do at all. I don't want to take you down the path where you're going to be memorizing a lot of formulas for this and formulas for that. There are very few questions that need you to do calculations. And we can try to forget about the calculations first and learn the most important other information. And then we can do some little calculations later if we have to, right? So that's cardiac output, that is stroke volume. We talk about the pulse pressure. The pulse pressure is the difference between your systolic blood pressure and your diastolic blood pressure. Okay? The difference between your systolic blood pressure and your diastolic blood pressure is your pulse pressure. So if you increase your systolic blood pressure and decrease your diastolic blood pressure or something, the pulse pressure will change. There are a lot of agents that cause change to the pulse pressure. You can increase the pulse pressure by increasing the systolic blood pressure. Maybe you give inotropic agents. Oh, now I've used another terminology, inotropy. Inotropy is contraction. So when we say inotropic agents, we are talking of medications that increase the contractility of the heart, the force of contraction. If you increase the force of contraction, you increase the systolic blood pressure, you're very likely to increase the pulse pressure. So you talk of things like norepinephrine, talk of things like digoxin, talk of things like milrinone. All of these medications are going to increase inotropy, contractility of the heart. I think dopamine can come in somewhere there. We'll come to those guys eventually. The next thing you want to know is end systolic volume. The end systolic volume. When we say end systolic volume, what do we mean? Is the amount of blood left in the heart at the end of systole. Is the volume of blood in the heart at the what? The end of systole. The next thing you want to know is the end diastolic volume. We said that the heart is filled in diastole. The heart is filled with blood in diastole. So after diastole has ended and the heart is full of blood, that blood in the heart is the end diastolic volume. The volume of blood in the heart at the end of diastole. So if I have 100 liters as my end diastolic volume, at the end of diastole, my heart is full, 100 liters. And now at the end of systole, my heart contracted. And now I have only 20 liters left. What does that mean? It means that I have pumped out 80 liters of blood. Or 80, yeah, yes, we are just giving examples. 80 liters of blood. That 80 liters of blood is my stroke volume. We said that the stroke volume is the amount of blood that is pumped out of the heart per beat as it beats. That blood is stroke volume. Well, if we have an end diastolic volume and then the heart beats and then we have an end systolic volume, this is the amount left. We can easily calculate how much has gone out of the heart. So the formula for finding what the stroke volume is going to be the end diastolic volume minus the end systolic volume. Again, we don't care much about the formulas, so you don't necessarily have to memorize them. There's an important connection I want to make here. The end diastolic volume, you want to remember this, is the same or technically the same as preload. The end diastolic volume is technically the same as preload. Preload is the pressure in the heart. Preload, the pressure in the heart before systole, before contraction. The preload, the pressure in the heart before contraction. And that pressure is, what's the word, proportional or technically proportionate to the amount of blood that is in the heart. The amount of blood that is in the heart. So end diastolic volume is equivalent to preload, one thing. Preload is also equivalent to stretch. What do we mean? When the more blood you have in your heart, the more extending you have, the myocardial fibers are going to stretch out, right? They are going to stretch out like rubber band. They are going to stretch out. So the more end diastolic volume, amount of blood in the heart at the end of diastole, the more stretch you have on your myocardial fibers, the higher the preload. Do you all get it? If you increase the end diastolic volume, you increase the stretch on the cardiac fibers, and you increase the preload. All of those things are connected with one another, and you want to remember them, right? You want to remember them. What else do you need to know? Afterload. So a lot of people make the mistakes of trying to understand. I don't know, I guess it's a little confusing to understand what afterload really is. Afterload is the pressure the heart has to pump against. And when we say the heart, please, we mean the left ventricle for all purposes here. Afterload is the pressure the left ventricle has to pump against. We would see how this is important. The left ventricle is this guy over here. The left ventricle is this guy over here. Supposed to pump blood through this aorta by going through this aortic valve. So if your aortic valve is stenosed, this left ventricle will be pumping against much more force. It's going to be when the valve is stiff, the left ventricle will be doing more work. That means you are increasing the afterload. The second thing is this. We gave an analogy before. Try blowing through a wide opening versus a straw. It is incredibly difficult, or much more difficult, to blow through this tiny straw than it is to blow through this wide orifice. Similarly, it's very easy to pump blood. If I tell you to pour water into this big pipe, very easy to pour water into the big pipe. It's much difficult to get fluid to move, to push fluid through this very narrow pipe here. And that's the same thing for the heart. That's the same thing for the left ventricle. If the blood vessels are dilated, wide like this, it's easier for the ventricle to just push blood into them. If the blood vessels are tiny, it's more difficult for the left ventricle to push blood into them. The width of the blood vessels is important. And the tinier the blood vessels are, the more resistance they have. So if the blood vessel is very tiny and it's more difficult, we can say that it's resistant, right? It's resistant to blood flow. The total resistance of the blood vessels in your body is called total peripheral resistance. Total peripheral resistance, the resistance across the blood vessels in the body. Now, the blood vessels that have the highest amount of resistance, or that contribute the highest to total peripheral resistance, are your arterioles. The arterioles contribute the highest to total peripheral resistance, and you want to remember that. So whenever there is vasoconstriction, when you say vasoconstriction, blood vessels close, whenever there is vasoconstriction, peripheral resistance increases. So here, vasoconstriction results in increased total peripheral resistance. If you increase the total peripheral resistance, you increase the afterload. Do you get it? If you increase the total peripheral resistance, you increase the afterload. If you increase the afterload, the left ventricle will be doing much more work trying to pump blood out of the heart. The left ventricle will be doing much more work to try and pump blood out of the heart, whether it's as a result of aortic stenosis or as a result of vasoconstriction and increased total peripheral resistance. And by the way, when you increase the total peripheral resistance and the left ventricle is doing much more work, what happens to blood pressure? The blood pressure goes up. and this is what we will call hypertension. So usually, as people grow older, your blood vessels get stiffer. This is the natural pattern, naturally. The blood vessels get stiffer as we grow older. And as the blood vessels get stiffer, it becomes more and more difficult. The size of the blood vessel is reducing. It's more and more difficult for the heart to pump blood. And there is more pressure exerted on the walls of these blood vessels, and we call that hypertension. It happens naturally with aging, or it can happen much quicker with atherosclerosis, we will talk about in one moment. Does anybody have any questions? No. All right. When we have hypertension, the heart is doing, you have a question? If you have a question, please ask quickly. You don't have to wait for me to ask if you have a question. Type your question into the chat. I would see it. Based on the oxygen saturation. Okay. Just type your question out and I'll come to it right away. All right. So hypertension. If we have hypertension, Candice, what is it about oxygen saturation? Tell me quickly before I jump into the pathology section. The syndrome, oxygen saturation syndrome particular. I don't get to type. Please, guys, type your questions before I ask you if you have a question, so that when I ask you for a question, you just send it into the group quickly and it will be easy, it will be faster. Okay, Candice, finish with your question and we'll come to it, okay? We'll come to it. I'm not sure what you mean. Based on the oxygen saturation, the syndrome particular, try to construct your question and then I'll respond to it, okay? If I don't answer your question on the group, we will talk. I will answer your questions live. So you'd actually hear me explain your questions. All right, hypertension is the result of increased afterload. We said that the arterioles, important, contributes the highest to total peripheral resistance. And that is very, very important. A little general pharmacology here. Vasoconstriction, if you remember, is the responsibility of your alpha-1 receptors, right? Alpha-1 receptors cause vasoconstriction. If you remember, your beta-1 receptors cause increased contractility of the heart, which we call inotropy. They also increase heart rate because they work on the heart, which we called dromotropy. We often talked about dromotropy. You don't have to remember dromotropy. Just remember inotropy, increased contractility, increased heart rate, dromotropy. Candice, I'll come to that question a bit, okay? Great. So that's alpha-1 receptor and beta-1 receptor. Beta-2 receptors causes vasodilation at skeletal muscles especially. Okay, so that's just a little information for you to remember. Bear those in mind. We would keep covering your general part, general pharmacy, go along so that we don't have to necessarily go to that aspect by itself. All right, so that is that. If nobody has any question, we'll move on to atherosclerosis. We'll come to, I was trying to spell Eisenmenger syndrome. We'll talk about Eisenmenger syndrome in a bit, okay? Atherosclerosis. Okay, so now we are going to deal with a little confusion that often happens with this topic. Arteriosclerosis. What does this mean? In pathology, one of the first things you want to know is that the definition of terminologies, again, I think I've said this before, give you the meaning of the word. If you split this word into two, some persons will tell me, what does that even mean? I'm not sure. We split this word into two. Arterio is blood vessel or artery. Sclerosis is hardening. So atherosclerosis is hardening of blood vessels. Atherosclerosis is hardening of blood vessels. But we have different aspects to atherosclerosis. We have different sections to atherosclerosis, different methods, different subtopics, sub-areas to atherosclerosis that you need to know. I won't go into excessive details that are irrelevant for the exam. Okay, right elections, good. We won't go into too many details that are not going to be necessary for your exam, but we're going to look at a few things. The first part you want to know is atherosclerosis. Atherosclerosis. Atherosclerosis is hardening of medium-sized to large vessels. Hardening of medium-sized to large vessels. This is the bigger concept that will lead us into our full cardiovascular pathology review. So before we come back to it, let's talk about the minor guys, or the sort of smaller guys, if we would call them that, okay? We have arteriolosclerosis. Arteriolosclerosis is hardening of what? The arterioles, hardening of the arterioles. Arterioles hardening, right? Arterio, artery hardening, general artery, or the arteries. Arteriolosclerosis, hardening of the arterioles. Atherosclerosis, this guy, atherosclerosis, hardening of medium size to large arteries. Arteriolosclerosis is hardening of arterioles, which are very small blood vessels. We have two types of arteriolosclerosis. One is pretty benign. It is caused by diabetes mellitus and essential hypertension. Okay, essential hypertension. That's the benign kind of arteriolosclerosis. The first part of it. You want to remember this. Now, what happens here? You have increased blood pressure, or you have diabetes mellitus. And because of diabetes mellitus, you're going to have hardening of some of these blood vessels. Give me a second. Right? You have hardening of some of these blood vessels. How do they harden? How do these blood vessels actually harden? You have the blood vessel. Let's say this was your blood vessel before. Okay? Now, there's increased pressure on the wall of this artery. And the same thing that happens in the heart begins to happen in this artery. It begins to thicken. And it thickens by adding some layers to itself. It begins to add some layers to itself. Do you see that? The artery begins to get thicker because it's getting thicker to be able to withstand the pressure. This is an adaptive mechanism, right? An adaptive mechanism to try to be able to withstand this pressure. But as it gets thicker, the lumen gets smaller. And another thing you want to notice is that I have used the pink or red-pink color to actually represent this. The materials that are used to harden this artery, these materials that are depositing inside the walls of this artery, are proteinaceous material. They are protein-like materials. Protein-like materials, and they appear pink. Because they appear pink, they are described as hyaline. So when you hear them say hyaline in pathology, they really mean pinkish material, proteinaceous material. Okay, so this first form of arteriolosclerosis is actually called hyaline arteriolosclerosis. It is hyaline arteriolosclerosis. And in hyaline arteriolosclerosis, your endothelium, these blood vessels have endothelium. Okay, the endothelium is the inner part of the blood vessels. This endothelium is infiltrated by proteinaceous or hyaline material. There is deposit of hyaline material in the endothelium of this blood vessel. Do we all get that? This guy just thickens the blood vessel, maybe decrease blood supply to some tissues. The person will have hypertension, diabetes. Both of them will do that quite well. The second one, though, is the very bad one. The second type of arteriolosclerosis, and that is the hyperplastic arteriolosclerosis. With hyperplastic arteriolosclerosis, you only have that actually in malignant hypertension. We only have that in malignant hypertension. Here, we have fibers added to the blood vessel. So if this is the blood vessel, you're going to have eccentric addition of fibers. You have addition of fibers in this manner, in that to the walls of that blood vessel, almost the way you have your onion. So if you try to open an onion, you see layers and layers and layers, concentric layers of fibers. That is called onion skinning. That is called onion skinning. It occurs in people with malignant hypertension. And the cells that are forming this onion skin, I don't know, they may ask you that on your exam, are actually smooth muscle cells. So the pressure from malignant hypertension is causing proliferation of smooth muscle cells. And the proliferation of these smooth muscle cells is causing thickening of the blood vessel. There are a lot of consequences that can come out of this, for sure, right? A lot of consequences. Now, imagine the tiny blood vessels you have in an organ like your kidney, for example. So if we have a kidney like that, we have arterioles, tiny blood vessels supplying these kidneys. When you have malignant hypertension, all those tiny blood vessels can burst open. You have those blood vessels burst open, and when you look at this person's kidney, you see dots that look like this. We call this kind, it's really small vessels that burst, tiny vessels that burst all around. We call this type of kidney a flea-bitten kidney. We call this type of kidney a flea-bitten kidney. We have other blood vessels in other parts of the body that may be damaged, and we'll talk about those when we talk about hypertension. That's it. All right. We'll talk about those when we talk about hypertension. That is atherosclerosis. The second part to atherosclerosis that we want to talk about is Mockingbird medial calcific sclerosis. Why is this guy called calcific sclerosis? Calcific. There is calcium deposition. Calcium is what is causing this sclerosis. Calcium is what is causing or responsible for the sclerosis in Mockingbird medial calcific sclerosis. So what happens in these people? You have deposition of calcium. Right? Deposition of calcium in the internal elastic lamina. The deposition of calcium in the internal elastic lamina of their blood vessel. This happens in medium. It tends to happen in medium arteries, like your femoral artery. In medium arteries, like a femoral artery. So imagine someone's femoral artery. Now we are depositing calcium in the internal elastic lamina of their femoral artery. Usually, these people are completely asymptomatic. Okay, they are completely asymptomatic. It does not cause the blood vessel to narrow. So if this is the person's blood vessel, this is your blood vessel, because it's thick. We have calcium depositing in this, in the middle, inside of this part. You have calcium depositing over here. It doesn't really do anything much. It just makes the blood vessel stiff. But although the blood vessel is stiff, it's still patent, it's still open. So blood is still flowing through this blood vessel. The only thing is that when you take an X-ray, you're going to be able to see this blood vessel. Normally, when we do X-rays, we don't really see blood vessels. But when we have calcification and calcium deposits, we are going to be able to see the blood vessel. They will look something like this. So when you do an X-ray in a patient, you will now be able to see their blood vessels. Do you see that? That is not supposed to happen. There is nothing really wrong. The blood vessel is working perfectly fine. It's just that now we can see it. We did not used to see it. And it gives off an appearance that we describe as pipe stem appearance. Because we can literally trace, it's almost like a pipe, although it's not straight like a pipe all the time, but it gives off what we would consider pipe stem appearance. Some people call it tram tracking effect, but it doesn't matter. This guy is not very big on the exam. Why? Because it's often an accidental finding. So if someone has this pathology, they're not going to present with symptoms, they won't feel any pain, nothing will be wrong with them at all. But if they have a fracture or they were involved in an accident and we have to do an X-ray of the lower limb to maybe fix a fracture to see how much damage they go, then we may find this. So you want to know that Mockingbird medial calcific sclerosis is often an incidental finding. It's usually an incidental finding. They did an X-ray of the lower limb for something completely different, and then they discovered that. Remember that it does not affect the intima. The intima is the medial part. This innermost portion of your blood vessel is called the intima, the interior part, okay? If something happens to the intima, then you can potentially cause narrowing of this lumen, right? You can potentially cause narrowing of the lumen if something happens to your intima. In Mockingbird medial calcific sclerosis, there is nothing wrong with the intima. And that is that. And finally, we go on to the big guy, atherosclerosis. We are not going to go through the entire process of forming an atheromatous plaque. We are not going to bother ourselves with that because that is not very important for your exam. However, you want to know that if we have a blood vessel like this one, this blood vessel has a wall, of course. Many times when you are born, well, not many times, all the time, when you are born with a clean blood vessel. The moment we begin feeding, we begin depositing some cholesterol on the walls of this blood vessel. So we start here, maybe we deposit a little cholesterol over here. Then we deposit this much cholesterol. We usually start with some tiny, tiny ones that we would call a fatty duct. Okay? We call this a fatty duct. And then you have a little bigger, we'll call this a fatty streak. What happens? Your macrophages begin to come in to eat up this fatty streak. The macrophages begin to come in to eat up. So let's put our fatty streak over here. Macrophages begin to come in to eat up this fatty streak. When the macrophages eat up this fatty streak, it's fat, right? If you've tried eating fat before, you don't really get to break down fat, like fatty food, stuff as much, especially when that fat is LDL. So your macrophages become full of fat. They become full of fat. They've eaten so much fat tissue. We now call these macrophages foam cells. You don't have to memorize this because they're full of fat, foam. They become foam cells. Now, they call more macrophages to help them eat. So we have more macrophages coming in to eat, more macrophages coming in to eat, until before you know what's happening, we have a cocktail going on. And in the center, we have our fatty streak, or even if we've deposited a lot of people that have high LDL levels will have a lot of fat deposition there, or cholesterol deposition, and they will have extensive macrophage action. Macrophages are trying to clean up, but it's not easy to do that, right? So they'll keep recruiting more and more macrophages, and then eventually they begin to destroy this blood vessel. So your body always acts to protect you. So what happens? The body tries to stop the process. It says, if I don't stop this, more and more macrophages will come, and as more macrophages will come, they'll keep expanding. Imagine we keep having macrophages like this going all over the place. Then this little thing that started over here would spread across the blood vessel, and your body knows to not let that happen. So what does it do? Your body thinks, what if we could make this stop? Let us just keep it here and let's cover it. So this is what happens. We have our fat guy in here. This is another stage, perhaps. And then we have these macrophages eating, and macrophages trying to eat, macrophages trying to eat. And then what happens? Your body begins proliferation of smooth muscle cells. There are smooth muscle cells in the media of this blood vessel. There are smooth muscle cells in the media of this blood vessel, the media. That's a layer of this blood vessel where we have smooth muscle cells. These smooth muscle cells begin to proliferate, and they proliferate and cover this stuff going on here, this feast of fat going on inside of this place. So we have macrophages inside, on the inside. We have fats on the inside. We have these macrophages eating fat and becoming foam cells. And then we have our smooth muscle cells trying to protect us by actually covering everything and keeping them in one place. Now that your smooth muscles have covered everything and kept them in one place, this is called an atheromatous plaque. This is called an atheromatous plaque. This atheromatous plaque has a number of parts. The only part I want you to really care about is this part here. This part is the shoulder of the plaque. Is the shoulder of the plaque. And the shoulder of the plaque determines how stable the plaque will be. If the shoulder of this plaque is well formed, then it's going to be very extensive. It's going to be extensive. It's very strong. It's difficult to break because blood is still flowing. Remember that blood is flowing, and blood is going to be hitting against the shoulder of the plaque as a whole. So if the shoulder is not well formed, it's possible that the plaque can break off. Other times, the blood can be hitting the crown, the tip over here, and that part can also break down. So we talk about the fate of an atheromatous plaque. So what's going to happen with an atheromatous plaque? This plaque can have damage. We could have damage to the shoulder or to the head, rather, the top part of this plaque. And once that happens, we will expose this center core once again. If we expose the core once again, then our blood is flowing. Our body would realize that, oh, there's something going on in here. Let's fix it. And we will have more and more macrophages begin to come and will actually worsen the process. So this plaque can become much worse. It can develop worse this way if you damage the head of this atheromatous plaque over here. The other thing that could happen, so we could say it could proliferate. Okay, it could proliferate. The other thing that could happen is that you could knock off the shoulder. So let's say the blood is flowing at high pressure, because most of these people that have atherosclerosis have hypertension as well. The blood is flowing at high pressure and knocks off the plaque. Now we don't have a plaque that is on one position. Please pay attention to this. When the plaque is in one position, we call it a stable plaque. It doesn't matter much. You don't have to really know. But okay, so we have a stable plaque. Now, when blood flows at high pressure, for example, and the shoulder is not very strong, the shoulder is what determines if it's stable or unstable. The blood can knock off the plaque. Now we don't have a plaque in one place. We have a plaque moving in the blood vessel. So this is your blood vessel. Now we have your plaque moving in the blood vessel. If this plaque is moving through the blood vessel, we would call that propagation, or as it travels, it is no more just a plaque, it's now an embolus. So we call that embolization. What is this? The consequence of embolization. As it travels along these blood vessels, it can come. Remember that your blood vessels get tinier. You have your big aorta, and then you have these smaller branches, and then you have the even smaller branches. It will travel until eventually it will come to a very small blood vessel, and it will occlude that blood vessel. If it occludes that blood vessel, we are going to have ischemia to that end organ. And this is, in fact, what causes myocardial infarction. So how does MI occur? We have a plaque in the coronary artery, right? Let me look at it back for a bit. We have a plaque in the coronary artery. A plaque in the coronary artery. This plaque can be a stable plaque. If it's a stable plaque, less than 50%, maybe it's occluding less than 50% of the coronary artery, we will probably never notice. If it begins to occlude greater than 70% of the coronary artery, the patient will begin to feel chest pain that we are going to call stable angina. But we'll come to all of those guys in one bit. But what I wanted you to take home from here is the whole process of forming an atherosclerotic plaque. We started with a fatty dot, a fatty streak. Macrophages came and ate them up, gave us some foam cells. Even more macrophages came. And then there was smooth muscle proliferation to try to ward off everything. And then we had a stable atheromatous plaque. This plaque could proliferate. This plaque could embolize. Sometimes this plaque could dissolve. This plaque could dissolve. Sometimes it can actually canalize. We call that recanalization. You don't need to memorize any of these processes. We can recanalize. But other times it can embolize. And this is what we are most scared of. Or it can proliferate. We are afraid of this. We are afraid of this. And that will lead us to the consequences that can occur as a result of this whole thing we've talked about. Myocardial infarction. Myocardial infarction is the worst of it all. That's where you get the heart actually dying because it's not receiving oxygen. But before we get to myocardial infarction, we have a lot of stages that we go through. If we have a plaque in the coronary artery, occluding greater than 70%, occluding greater than 70% of the blood vessel, this patient is more likely to start feeling chest pain. We call that chest pain angina. Angina. Now, there are different types of angina. If we have a stable plaque, the plaque is just there, but it's occluding 70% of the blood vessel, we are going to call this a stable angina. And we'll see what happens in people with stable angina. So when the patient begins to walk or run, the heart begins to increase activity. The heart rate begins to increase, right? So when the patient walks a long distance, when they run a while, when they exercise, they'll feel pain, chest pain. That chest pain is angina. And another thing you want to know is that chest pain is going to be relieved. So when they rest, they feel better. When they walk out, they feel pain. The question is why? During exercise, there is increased oxygen consumption and demand in the heart. So when you walk out, when you're exercising, your heart begins to beat faster. It begins to use up more oxygen. At this point, if you have occlusion, you're not going to be able to provide the amount of oxygen that your active heart needs. And so the way for the heart to tell you, I need oxygen, or for your muscles to tell you, I need oxygen, is that you feel pain, right? So this person is going to begin to feel pain. Decreased oxygen consumption and demand, pain. That's the reflection. This patient is going to begin to feel pain, and that pain is called stable angina. What you want to know is that when this patient rests, the pain goes away. So the pain of stable angina is relieved by rest. Or what if they take a medication that opens up their blood vessel by a lot? That will also help. And that medication is nitroglycerin. So stable angina is chest pain relieved by rest or nitroglycerin. That's the definition you want to bear in mind. Stable angina is chest pain relieved by rest or nitroglycerin. And when does the chest pain occur? When there is exercise or exertion. So you're going to hear this phrase very commonly. Chest pain on exertion that is relieved by rest or nitroglycerin. The second thing we want to talk about is unstable angina. Or before we talk about unstable angina, perhaps we should talk about prinzmetal angina. Prince-metal angina is a type of angina where we don't really have an atheromatous plaque. What happens is that you have hyperreactive coronary artery. Okay, hyperreactive coronary artery. So you're getting vasospasms. The coronary artery are twitching, contracting because they are reacting to something. That is what prince-metal angina is. We are going to have vasospasms. I hope everybody gets all of this to this point. Now, whenever you have vasospasms of this nature, your blood vessel is going to undergo constriction. There will be decreased blood supply to the heart, and the patient will feel pain. Cocaine can also cause vasospasm and lead to that kind of chest pain. And I'm going to ask you guys on the group much later to give me answers as to the mechanism of action of cocaine. How does cocaine carry out its effect on the heart? So we have these vasospasms from prince-metal angina. We treat these guys with calcium channel blockers. Do you remember any other disease that looks just like prince-metal angina, or exactly, or at least has similar mechanism of action to prince-metal angina? Are you thinking about Raynaud phenomenon? Remember that in Raynaud phenomenon, there is vasospasm or constriction, vasoconstriction of blood vessels, obviously of blood vessels, of the blood vessels supplying the upper limb or the lower limb. That is the same thing that happens in Raynaud phenomenon. And we also treat Raynaud phenomenon with calcium channel blockers. So I hope you are seeing the patterns that are forming here. The next thing we want to talk about is unstable angina. Unstable angina occurs when there is way greater than 70% occlusion. Maybe there is like 90% occlusion, right? The blood vessel is almost totally occluded. That's unstable angina. Here they are going to have chest pain on exertion or at rest, not relieved by nitroglycerin. This chest pain from unstable angina is not going to be relieved by nitroglycerin. You want to bear that in mind, right? The chest pain from unstable angina is not going to be relieved by nitroglycerin. Okay, that is one thing to bear in mind. You want to also remember that unstable angina cannot be distinguished from non-ST elevation MI. I'll tell you why this is in 1 minute. People with unstable angina are going to get ST depression on EKG. I'll tell you why that is the case. The heart looks like that. We have this thick wall. And if you look at this wall, blood vessels are supposed to come and supply the heart this way. The heart does not receive blood supply from within itself. It needs coronary arteries to supply it. And the last part of the heart to receive blood supply is this innermost part we call the subendothelium. So if blood is coming to supply this heart, it's going to first get to all these parts before it gets here. So you can imagine if there's an occlusion, like you have in unstable angina, this part of the heart will not get enough blood supply. And whenever there is endothelial or let's just use subendothelial. Whenever this subendocardium or subendothelial area does not receive sufficient blood, there will be ST depression on EKG. You want to know that. If the subendocardial region, I think that's the best way to put it. If the subendocardial region does not get enough oxygen, enough blood supply, the way we know is that there will be ST depression on the EKG. Now, when you completely cut off blood supply from the heart, like you have in MI, you're going to have transmural ischemia, meaning that there is no blood at all to any part of the heart. So every part of the heart is starving of blood. Every part of the heart is starving of blood. That is going to be, what do we call it? That is going to be transmural ischemia. And the way we know that there is transmural ischemia is that we are going to see an ST elevation on EKG. Now, ST depression on EKG can be seen in unstable angina and non-ST elevation MI. So how do we differentiate the both of them? The difference is that in unstable angina, the heart tissues, the cardiac myocytes are not dead. The cardiac myocytes are not dead. Because they are not dead, there is no increase in their content in blood. This is how things increase in blood. Okay, so you already memorized from somewhere perhaps that if someone has MI, you see increased troponin in the blood, increased CKMB. But troponin and CKMB are really contents. They are really contents of the heart cells. So inside of your heart cells, we have troponin and CKMB. That's normal. When the cell dies, it bursts open and then it releases these things. So in unstable angina, these cells have not died. They've not undergone necrosis just yet. So there is no increase. No, I should probably do it somewhere else. There is no increase in cardiac enzymes in unstable angina. In non-ST elevation MI, there's increase in troponins and there is increase in CKMB. There's increase in troponins and there's increase in CKMB. Usually, people with unstable angina or even non-ST elevation MI will have chest pain for at least 30 minutes. Okay, so what you're looking for really in this situation is going to be a patient, maybe a 50-year-old male with chest pain that has lasted maybe 30 minutes or for the past hour or something of that nature. When you see that, you're thinking MI, you're thinking non-ST elevation MI, you're thinking unstable angina. The difference is going to be the troponin level. The first thing we do when a person comes in with a chest pain like this is that we do an EKG. Okay, because that's the fastest thing to do. These enzymes are not going to be elevated until after a certain time. So maybe after 4 to 6 hours, you're going to have increase in your enzymes. So the first thing you want to do is an EKG. You don't want to wait for the patient to die because you're trying to wait for troponins to be elevated. That's important. An EKG will tell you if it's ST elevation MI or ST depression MI. And in each of those cases, we have a different way of approaching treatment, of treating the patient, right? You begin to treat. But that's not something you should worry about for step 1. That's something you should worry about for step 2. So everybody gets aspirin. When do you use beta blockers? When do you use percutaneous intervention? You learn all those things when you are ready for your step 2 exams. Do you guys understand everything we've done so far? Before we begin to talk about the complications of MI. All right, complications of MI. What happens when people get myocardial infarction? And what blood vessel is most commonly affected when people have myocardial infarction? The most commonly affected blood vessel is the left anterior descending artery. The most commonly affected vessel in myocardial infarction is the left anterior descending artery. And that artery is the one that supplies, remember, the inferior part of the heart. We saw this image the left anterior descending artery is the blood vessel that supplies this part of the heart, right? Between the right ventricle and the left ventricle at this end and the inferior part of the heart. You want to know that when people get MI, what do you expect to happen? First, immediately there's no blood supply to the heart. The electrical system of the heart, the nerves in the heart, they all undergo ischemia, and these nerves are going to malfunction pretty fast. If they malfunction, this patient is going to have arrhythmias. Most of the time, they will get ventricular fibrillation. And this is number one killer of people with myocardial infarction. Most of these patients will die from ventricular fibrillation. You want to know that. This is what will kill them before they get to hospital, for example, or even during their duration in the hospital and while they are still managed. This is a very common cause of death in people with arrhythmias. We have two types of heart failure. We have forward failure and backward failure. Forward failure and backward failure. You want to remember that we have the left ventricle, right ventricle. We said initially, if this is your left ventricle, we'll break them down. Your left ventricle is pumping blood to the rest of the body. But your left ventricle is receiving blood from the left atrium. And your left atrium is actually getting this blood from the lungs. The left atrium is actually getting this blood from the lungs. So when the left ventricle fails, when there's left heart failure and the left ventricle fails, we are technically talking about heart failure at this point. Blood is going to back up into the lungs. Because this blood, if the left ventricle cannot pump blood anymore, what happens? Blood accumulates in the left ventricle, backs up into the left atrium, backs up into the lung. And when blood backs up into your lungs, that is pulmonary edema. Now, we've actually technically started talking about heart failure. So I think I'll just talk about both of them in tandem. But before we move further from there, this heart has muscles, right? This left ventricle has muscles. We've seen the muscles before. And these muscles have attachments. If this is your left ventricle, this is the muscle. We have attachments to the muscle. Right here, somewhere here is your mitral valve. Somewhere here is your mitral valve. Then your aorta goes like that. Somewhere here is your aortic valve. This mitral valve is attached to a string of fibers. A string of fibers that connect to muscles in the heart. Your mitral valve is attached to there are fibers that hold this mitral valve in place. And those fibers are connected to a group of muscles like this that hold the valve in place. If you damage these muscles, if there's ischemia and these muscles are damaged, this valve cannot be held in place. These fibers that hold the valve, that attach the valve to the muscle, are called chordae tendineae. These fibers are called chordae tendineae. And these chordae tendineae fibers will rupture if there is ischemia. They will detach from this base. We call that chordae tendineae rupture. And once that happens, it will result in insufficiency. That valve will no more work properly, and this patient may develop mitral insufficiency. So mitral insufficiency, therefore, becomes a complication of myocardial infarction. You're going to hear a murmur of mitral regurgitation, a holosystolic murmur. The other thing that can happen is that there could be ischemia. This ischemia could actually affect the interventricular septum rather. Imagine that there's ischemia that affects this part of the heart. Imagine there's ischemia that affects the interventricular septum. That septum is going to become weaker and weaker, right? And eventually it's going to completely give way. Now, whenever you damage the tissue, macrophages are going to come in and begin eating up this tissue. I didn't tell you about the timeline of an MI. So within the first 24 hours or so, the ventricular fibrillation is more likely to occur. Within the first 24 hours, the first few days, mitral insufficiency can also occur. Now, between day 3 to 7, your macrophages would have macrophages come in at around day 3, and then they begin to eat up the heart. Any part of the heart that was involved, that was damaged, the macrophages will eat them up. And imagine your macrophages eating your heart. You're going to have a hole in your heart. If the interventricular septum was involved, then the macrophages will eat your interventricular septum. By day 7, between day 7 and 10, that's when they would have done their job. It would be maximum, and you would have a rupture and create a VSD. So again, people with MI would develop a VSD. This will come at around day 3 to 7. If it is the wall of the heart that was involved, the wall of the heart here that was involved, then you would eat the wall of the heart. If you eat the wall of your heart, you will rupture the wall of your heart. If you rupture the wall of your heart, blood will leak out of your heart, right? And you develop a cardiac tamponade. The patient develops a cardiac tamponade. So cardiac tamponade becomes a complication of myocardial infarction. What is cardiac tamponade? You may remember from your school that during cardiac tamponade, you rupture the heart, blood fluid leaks out of the heart. Now, although we have our heart like this, we actually have another layer of tissue that protects the heart, okay? We have a layer of tissue, actually 2 layers, that protects the heart. We call this the pericardium. Now, when you have fluid or blood leaking out of your heart into your pericardial space, that is what we call tamponade. This blood is going to compress the heart. It's like, imagine when you're inside of water, and you're trying to, it's like the water puts pressure on you. It's difficult to move your hand apart. It's difficult. You don't move freely inside of water, basically. That's what goes on in the heart. The heart cannot relax completely. It cannot contract fully. There's just that wrong the whole dynamic of cardiac contraction and relaxation is just out of it, right? As a result, the heart will pump with less pressure. So one of the things you have with cardiac tamponade is going to be hypotension. If you are underwater and you talk to somebody above water, or if you are above water and you're listening to somebody talk to you from under the water, you can hear that their sound is muffled. You don't really hear them clearly. Similarly, in cardiac tamponade, when someone has fluid around their heart, when you place a stethoscope on their chest to listen to the heartbeat or listen to heart sounds, you will notice that the heart sounds will be muffled. So one of the things we have in cardiac tamponade is muffled. Some people call it distant. It means the sound, it sounds like it's coming from afar. Distant heart sounds. Distant heart sounds. And then when you try to do an EKG, for example, the electrical signals are not going to be smooth, right? You don't get smooth signals because of fluid interface. You're not really picking up the signals from the heart correctly. We call that pulsus alternans. Another thing you want to notice is that if there's fluid around your heart compressing the heart, it's difficult for the heart to receive blood. The ventricles don't feel correctly. The ventricles don't feel the way they're supposed to feel. And as a result, there's backup of blood. So imagine, especially on the right-hand side, this is your right ventricle, and this is your right ventricle, and we have the left ventricle, the right atrium sitting on it. And then we have the inferior or superior vena cava, for example, bringing blood into the right side of the heart. So superior vena cava will bring deoxygenated blood into the right atrium. It will get into the right ventricle, not left, right? If you have cardiac tamponade, you're compressing the heart. The right ventricle cannot receive all this blood. So there's backup of blood into the superior vena cava. If you have backup of blood into the superior vena cava, it will back up into your carotids. It goes higher up into the carotids and jugular. No, carotids are arteries. Oh my God. Sorry, not into the carotids. It backs up into the jugular veins. So these jugular veins will become distended. So in people with cardiac tamponade, you're going to see jugular venous distension. These three findings together constitute what we call the Betz triad. These three findings together constitute what we would call Betz triad. That's cardiac tamponade. What else could happen in people with myocardial infarction? If you have ischemia of the heart muscles, the wall of the heart, you have damage to the wall of the heart. Oftentimes, this pericardium is also involved. Okay, this pericardium is involved. You're going to have neutrophil infiltration, especially in the first 24 hours. After the first 24 hours, you're going to have neutrophils coming in. I told you we have two layers here, right? So let's say this pericardium has two layers. We have a visceral pericardium and we have a parietal pericardium. So we have two layers. Now we are going to have this pericardium full of neutrophils. The pericardium is full of neutrophils. Imagine you're having neutrophil there. That pericardial layer, the layer between the two pericardium, is supposed to be smooth. There's not supposed to be anything there. Now, when there is something there, you increase the friction. When the one pericardial layer rubs against the other one, there is friction created because of the presence of neutrophils inside of that place, right? That friction, when you listen to the heart, you can hear it, and we call that a friction rub. We hear friction rub in acute pericarditis. We hear friction rub in acute pericarditis. We hear friction rub in acute pericarditis. The other thing you want to take note of also is that when there is acute pericarditis, you're going to have diffuse ST elevation. There will be widespread diffuse ST elevation, acute pericarditis. Friction rub, very big, very important, diffuse ST elevation. Another thing you have in people with pericarditis is positional chest pain. Positional chest pain. You have chest pain that gets better with sitting up and leaning forward. They will tell you that the patient has chest pain that gets better when he sits upright and leans forward. That's what you want to bear in mind. That is positional chest pain. You have that in acute pericarditis. All right. They may also develop chronic pericarditis. We are still looking at complications of MI. Chronic pericarditis. Chronic pericarditis is going to occur weeks later, months later, when this MI has started resolving and you actually have fibrosis around the heart. Okay, you have fibrosis around the heart. That's what causes chronic pericarditis. Now, when they have chronic pericarditis, you're going to hear a pericardial knock. You hear a pericardial knock. That is chronic pericarditis. Finally, we'll talk about Dressler syndrome. We'll talk about Dressler syndrome. Dressler syndrome is autoimmune reaction that occurs after at least 2 weeks. Okay, so it's almost like your immune system looks at your heart and says, oh, this heart is ischemic. Is that normal? It's not normal. That heart, your heart becomes like a foreign body, right? So the ischemic heart is almost like a foreign body, and the body and our immune system attacks it. Usually, the only thing I want you to remember here for your exam is that there's going to be increased eosinophils. This is the most important thing to remember. It is autoimmune reaction to the dying heart or the dead heart, and it occurs after at least 2 weeks from the time the person had the MI. Do you guys understand everything? Molly, are you still there? Can you hear me? I'm about to give you guys a break, hopefully. But can you guys understand everything we've done up till this point? Can I hear from everybody else that is here? I've heard Candice, I've seen you a lot. Molly, are you there? Eli, are you there? Victor, did Victor join the session? Is everybody there? Can you still hear me? All right. So great. We have a lot to cover. I thought we would be able to do this in a very short time. Apparently, we have so much to do. We wouldn't be able to do that. So we have to work our way around all of this. All right. So we have increased eosinophils in Dressler syndrome. Yes, Molly, I can see your comment. Thank you. We have increased eosinophils in Dressler syndrome. That is the most important thing you need to remember. That is the most important thing you need to remember. The next thing we want to go into is going to be heart failure. Okay, if someone has MI, many of the times people with MI are going to develop heart failure. Remember, we talked about hypertension earlier. If you have hypertension, your ventricles are going to get larger because they're doing extra work. And then because they're doing extra work, they'll undergo ventricular hypertrophy. I didn't talk about something specific about hypertrophy that will be helpful for your basic pathology knowledge. When there is pressure in the heart, you have a ventricle like that. Pressure is going to distribute evenly across the wall of the ventricle. Pressure is going to distribute evenly across the wall of the ventricle. So as the heart gets thicker, every part of the ventricular chamber will thicken at the same time. They'll thicken at the same pace simultaneously. So as this part is getting thicker, everybody else is getting thicker with it. So we have the first layer of thickness, but the hypertension gets worse. Everybody gets thicker as well. We have another layer of thickness. The hypertension did not resolve. The heart continues to get thicker and thicker. What has happened here? If this was someone's ventricle, what you will notice is that the size of this ventricle is now shrunken. As the wall is getting thicker and thicker, first hypertrophy is occurring, right? As hypertrophy is occurring, the size of this chamber inside of this place, this is the chamber, right, is getting smaller. The size of the chamber is getting smaller, right? In addition to that, so these are things you can see with hypertension. So let's talk about that before we go to heart failure. The chamber size is getting smaller. If there is a blood vessel, remember we talked about blood supply to the heart. We said the coronary artery is supplying it. If it's getting thicker and thicker, it gets more and more difficult for the coronary artery to actually supply blood to the left ventricle. And that increases the risk for ischemia. And ultimately, myocardial infarction. So hypertension becomes a big risk factor for myocardial infarction. The second big risk factor is going to be diabetes, because diabetes will lead to atherosclerosis. In fact, diabetes is the highest risk factor, the worst risk factor for myocardial infarction. Take note of this statement. You may need to remember it. The highest risk factor, most common risk factor for MI is hypertension. The worst risk factor for MI is diabetes mellitus. You want to remember that. The most common risk factor is hypertension. The worst risk factor is diabetes mellitus. So we increase risk for ischemia. Now, this ventricle that is looking smaller chamber, hypertrophy, as it gets thicker and thicker, it gets stiffer and stiffer as well. I told you that the fibers are added evenly. So we have this layer added evenly. This type of addition of fibers is called concentric hypertrophy. Concentric hypertrophy. We are going to talk about dilated cardiomyopathy, and I'll tell you about the second type, which is eccentric hypertrophy. Okay, we'll do that. So the worst risk factor is diabetes mellitus. When people have hypertension will cause hypertrophy, decreased chamber size. Now, when your ventricle is filling with blood, this is where we are coming to. When your ventricle is filling with blood, this hypertrophic ventricle, it's like the heart is supposed to be relaxing in diastole and filling with blood, but that's not what's happening here. The heart is stiff. It's difficult for relaxation to occur. You know the way it is when people build their muscles very huge. They can't really move their hands anymore. They just walk like that. That's what's going on with the heart. The heart is so stiff, it can't move itself anymore. It's just like that. So when it's trying to feel, it's like, think of when you hear, if you've seen a bodybuilder, I tell them to stretch a bit. What do they do? It's like it's a lot of force to stretch. So think of the heart as using a lot of force to stretch when you're trying to feel it, right? You're feeling a stiff ventricle. That stretch that the heart does, the feeling of that stiff ventricle produces a sound that we can hear. And that sound is the S4 heart sound. So the S4 heart sound is the sound you hear when there is left ventricular hypertrophy and when you are feeling a stiff ventricle. So when there's blood flowing into when there's contraction of the atrium against a stiff ventricle, that's like, if you want to put it more nuanced, I guess. If there's contraction of the atrium against a stiff ventricle, contraction of the atrium against a stiff ventricle, you hear the S4 heart sound. When we talk about dilated cardiomyopathy again, we will talk about the S3 heart sound. We'll talk about eccentric hypertrophy and the S3 heart sound. Does everybody get it so far? You hear the S4 heart sound as a late diastolic murmur. You hear the S4 heart sound as a late diastolic murmur. One of the questions I will send to your group this week is going to be related to S4 heart sounds. I hope you guys get it right when you see that question. So please remember this. It is a late diastolic murmur. It will always, you hear it usually and always in people with what? Hypertension. Does everybody get it so far? Great. That is that for that. Now we can actually talk fully about heart failure. As we were saying before, we have two types of heart failure, or two forms that can happen. We could have forward failure. We could have backward failure. You could have forward failure, and we could have backward failure. Forward failure and backward failure. So what happens in forward failure? Forward failure means the heart is not able to push blood forward. It just makes sense. Backward failure means the heart is not able to stop blood from moving backward. I think that's a simple way to put it, okay? So this is your heart. We've done so many hearts today, actually. And the heart is supposed to pump blood to your organs, right? To your different parts of the body. If the heart fails and is unable to pump blood to different parts of the body, we have a forward failure. There are a lot of organs that will be at risk of developing ischemia and hypoxic injury, especially the organs that receive the most amount of blood. Number one is going to be the kidneys. The kidney receives about 25% of blood normally on a normal day. So you can imagine that when there is heart failure, the kidney is not going to receive 25% of blood, maybe to receive 10%, I don't know, or 5% or something of that nature. If the kidney is now receiving 5% of blood, 10% of blood, what's going to happen to the kidney? It will undergo ischemic injury. And there is a part of the kidney that is very frequently damaged. It is the proximal convoluted tubule. The proximal convoluted tubule is very commonly damaged because that's the part of the kidney that does the most work, right? So it needs more oxygen, it consumes more oxygen and demands more oxygen. So you're going to have proximal convoluted tubule damage in the kidneys. What do we call this condition? Acute tubular necrosis. You want to remember that in acute tubular necrosis, you're going to see muddy brown casts in urine. You're going to have muddy brown casts in the urine. So please remember that the kidney is one big part that's going to be damaged. There are other parts of the body that are also very prone to ischemia. One is your splenic flexure. Your splenic flexure. So when you think of your colon, right? Your colon, we have the colon like that. We have the appendix somewhere here. We have the ascending colon. That's not anybody's colon. We have the ascending colon. We have the transverse colon. We have the descending colon that becomes the sigmoid colon. And that's something like that, right? Okay, that's one bad colon. But something of this nature. This is what we have as someone's colon, for example. At this point right here is where we have the splenic flexure. It's called the splenic flexure because if we look at the anatomy of the full body, your spleen is going to be somewhere above here, okay? So it's not supposed to be a kidney, it's supposed to be a spleen. I don't know how to draw anymore. All right. But the spleen is supposed to be somewhere here, okay? So it's like close to that juncture. So we'll call this the splenic flexure. The splenic flexure is a watershed area. Let's call this the full name of the disease, mesenteric ischemia. The splenic flexure is a watershed area. Watershed areas are parts of the body that are very prone to ischemic injury. Okay. Now, your superior mesenteric artery supplies blood to your ascending colon and transverse colon up to this point. Superior mesenteric artery. The inferior mesenteric artery supplies blood from this point all the way to the sigmoid colon, somewhere above the pectinate line. Inferior mesenteric artery. And both of them meet at around this point. You remember what happens at the border between two countries. When you look at the borders between any two countries, nobody takes care of that part because it's nobody's problem. Right? It's just the border. That's what happens here. So this is the border between the inferior mesenteric artery and the superior mesenteric artery. Nobody cares about it. So it's very prone to ischemic damage. And when there is heart failure, for example, people can damage that part because of decreased blood supply. They develop acute mesenteric ischemia. I hope you guys are following me. So that's another part. The next thing that can happen is that there could be decreased blood flow to the brain, results in strokes. We also have a lot of watershed areas in the brain. One other watershed structure that you may need to know is the hippocampus. Note before, the hippocampus is prone to ischemic damage. The hippocampus is prone to ischemic damage. That's important. You may want to remember that as well. That is forward failure. That's what forward failure is all about. Then we talk about backward failure. Backward failure. Backward failure means that blood backs up. That's all. Blood is supposed to come into the left ventricle from the lung into the left atrium, into the left ventricle. Now, that is not going to happen anymore because the left ventricle is basically just sleeping. It cannot pump. It cannot pump properly. Now, if the left ventricle is not able to pump blood properly, blood will pool inside the left ventricle. As it pulls inside the left ventricle, it will accumulate in the left atrium as well. And from the left atrium, it will go back to the lungs. Which said this already before, the patient will develop pulmonary edema, fluid in the lungs. Common question on your exam. How do you manage pulmonary edema? You give loop diuretics, furosemide. What else could happen? Imagine that the right heart is failing, because usually when one part of the heart fails, the other heart also fails. The most common cause of right heart failure is going to be left heart failure, okay? So imagine that there's right heart failure. Right heart failure. Your right heart is no more filling with blood as it ought to. So what's going to happen? Again, the blood will back up. If you look at the heart, there is the inferior vena cava and the superior vena cava, right? The inferior vena cava is bringing blood from the liver, right? Is bringing blood from the liver. So blood will back up into the inferior vena cava from the right atrium and then back into the liver. This blood is going to fill up the liver. The liver will become engorged. You have hepatomegaly. You have hepatomegaly. The liver becomes enlarged. When this liver is enlarged, you take a slice of the liver. If we look at the liver, maybe take a picture of it or take a cut, you see dilated vessels, dilated canaliculi. The liver begins to look like this. Somebody looked at it, apparently doctors like food and felt it looked like what you used to cook in your kitchen. So they called this what? Nutmeg. You know this what this guy is, right? They call this nutmeg liver. The liver looks like a nutmeg because you see all these parts are dilated. It's dilated. See that? Dilated. These blood vessels become more pronounced. Look at that. That is nutmeg liver. There are two things that cause nutmeg liver that you want to know. The first one we are already talking about, right heart failure. The second is Budd-Chiari syndrome. The first is right heart failure. The second is Budd-Chiari syndrome. We'll talk about Budd-Chiari syndrome. We'll get to GI and passing like that, right? Budd-Chiari syndrome. Both of them are going to cause this nutmeg liver. You get that? Eventually, it backs up from the liver. Remember that the liver has the portal circulation and all of those guys. It backs up into the portal system and then to the rest of the body. This patient will present with pedal edema. Their lower limb will be swelling. If it becomes very bad, they may develop generalized edema we call anasaka. Anasaka is generalized edema, right? Anasaka. All of these are things that happen. The superior vena cava blood will also back up. It will back upwards, superior vena cava into the jugular. These patients will present with jugular venous distension. So whenever you're reading a vignette and you see jugular venous distension, you should be thinking of heart failure, thinking of cardiac tamponade. Remember, it's one of the components of Beck's trial, right? Jugular venous distension. They may have puffy face, they may have puffy eyes, and a whole lot of other activities that can happen. But these are the basic presentations you will have for a person with heart failure. If you remember all this information, you won't have a problem diagnosing heart failure. You won't have a problem interpreting a vignette when they give you a person with heart failure. Now, heart failure has a definition, obviously. Usually, the way we estimate the activity of the heart is that we check for ejection fraction. If your ejection fraction is less than 50, 45, I think it's 45. I hope I'm not mistaken here. Confirm this. I'll confirm it for you guys. So if it's less than 45, I think, or 55, the person is going into heart failure. I think it's 55. I don't know why I'm skipping my mind now. If your ejection fraction is less than 55 or thereabouts, you're going into heart failure. If it drops as low as 35, that's actually very, very severe. That is what heart failure is. Do you guys all get it so far? I've not heard from Eli. Is Eli still here? Eli, can you hear me? If you can hear me, oh yes, all right. So as your ejection fraction drops, the person develops heart failure. That is what we mean. And when people have heart failure and you don't have blood pumping throughout the body or supplying tissues, we call this cardiogenic shock. Okay, for your exam, as long as this exam is concerned, every time you see blood pressure 90/60 or less than 90/60, I want you to think that this patient has shock. Do you guys get it? Every time you see someone with a low blood pressure, especially once it gets to 90/60, 90/50, 70/something, diagnosis shock. Then you now start from there to look for which kind of shock it is, right? When we get into the group, somebody remind me, I'll teach you guys the different kinds of shock and how they present and how to figure out which type of shock they're giving you in a VNet. We are interested in cardiogenic shock now. Cardiogenic shock is when you have heart failure and then the blood pressure is low. So if you see the blood pressure is very low in the question and you're thinking, okay, how do I know it's cardiogenic shock? You're going to see signs of heart failure. You're going to see JVD. You're going to see shortness of breath because of pulmonary edema. So if there's pulmonary edema, this person will have shortness of breath. You may see that. All of those things will be indicators and pointers that a patient has cardiogenic shock. I'll send questions. We have a lot of challenges you're going to be doing during the week. You're going to learn more about all of these things. So we move from talking about heart failure to actually beginning to look at cardiomyopathies. Cardiomyopathies. There are three types of cardiomyopathies that you are going to need to know, right? There are three types of cardiomyopathies that you are going to need to know. Hypertrophic cardiomyopathy, I guess, is everybody's favorite. The second is going to be dilated cardiomyopathy. Dilated cardiomyopathy. And the third is going to be restrictive cardiomyopathy. When we talk about hypertrophic cardiomyopathy, there are a number of things you want to know. There's a lot of information in your first aid. So the mutation, the gene involved, and all of those kind of things. You can do that. Most people that will get hypertrophic cardiomyopathy probably inherited it from somebody. It's probably in the family, right? Because about 70% of people with hypertrophic cardiomyopathy are familial or inherited. And if it is inherited, most of the time, the mode of transmission or mode of inheritance is going to be autosomal dominant. Okay, mode of inheritance is going to be autosomal dominant. They may ask you sometimes what genes are involved in hypertrophic cardiomyopathy. The gene mutations involved are gene mutations in genes coding cardiac fibers. Mutation in genes that code for cardiac fibers. Okay, genes like your beta myosin, like the beta myosin gene, right? You don't have to memorize all these things. They're not too important, but if you remember them, that would be great. Your beta myosin gene, for example, sarcomeric proteins, all these proteins that make up the structure generally of the heart, is where you have these mutations. But the most important things are the additional findings you have. People with hypertrophic cardiomyopathy have distinct features that you have to know. They have distinct features that you have to know, and those are what we are most interested in. The most important of these distinct features is an asymmetrical. Is that how to spell asymmetrical? Asymmetrical, what do we call it? Enlargement, hypertrophy of the interventricular septum. With disarray of fibers. I will explain what I mean right away. With disarray of fibers. Right? With disarray of fibers. We are going to have asymmetrical hypertrophy of the interventricular septum with disarray of fibers. And what do we mean by that? Let me see if we have an image with that for you. Nope. So I'm going to just draw it and show you. If we have this as our heart, for example, if we have this as the heart, for example, if we have this heart, this is what it should be on a normal day. If it undergoes hypertrophy, you expect it to look like this. Everybody is enlarged evenly. But what if this happens? Now there is asymmetric enlargement. You see that this guy is significantly bigger than both the right and the left. This is what we call asymmetric hypertrophy of the interventricular septum. And when you look into this guy, what you're going to notice is that the fibers are going to be in disarray. They are not organized properly. Okay, this is very characteristic of hypertrophic obstructive cardiomyopathy. The next thing you want to know is that oftentimes this septum is so huge that it actually occludes the valve. It obstructs the valve, the aortic valve. So if we have this as your right ventricle, for example, you have the aorta come out that way. You have the aortic valve over here. This muscle here is so thick that it obstructs the valve. Do you see that? It's so thick. It's going to be difficult for blood to pump out of the heart. We call that mechanical obstruction. We call that mechanical obstruction. So it's almost as if they have aortic stenosis, but they don't have aortic stenosis. It's just that the interventricular septum is so big, it's mechanically occluding that portion of the heart. So again, when the heart contracts, you're going to hear a systolic ejection murmur. That's how you're going to see it many of the times described. It's a murmur that you hear during systole as blood tries to be ejected from the heart. It is the murmur of hypertrophic obstructive cardiomyopathy. Do you get it? Again, it's hypertrophy as a result of pressure, although there is genetic abnormality. Fibers are added in parallel. The fibers are added uniformly, like we said before with the other hypertrophy, because of hypertension. Fibers are added uniformly, and we will have concentric hypertrophy. We will have concentric hypertrophy. We say that the fibers are added in parallel. You want to remember that as well. We'll move quickly. I will move on to dilated cardiomyopathy. We've shot beyond our time. I wonder if you guys are exhausted. I hope you are keeping up with me. Okay, we'll talk about dilated cardiomyopathy. Now, what causes dilated cardiomyopathy? That's the first question anybody is going to ask. What is dilated cardiomyopathy? Dilated cardiomyopathy simply means that the chambers are dilated. So if this is what your ventricle is supposed to look like on a normal day, left ventricle is probably slightly bigger than the right one. Now the ventricles look like that. Look at that big ventricle. This is dilated cardiomyopathy. The walls may also get thicker. The walls may get thicker, but the chambers are significantly much more dilated, right? The chambers are significantly much more dilated. That is what dilated cardiomyopathy is all about. In dilated cardiomyopathy, we have a problem with contraction. So the heart is dilated, it's just fat, and it's filling with fluid. It cannot contract. So during systole, we don't get contraction of the heart. We call that systolic dysfunction. Compare that to hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, the heart is so big, when it contracts with power, very large force. We don't have a problem with contraction. But when it's time to feel the heart, it's like the muscular guy, it cannot relax, right? So we have a problem with diastole, with feeling. So hypertrophic cardiomyopathy will have diastolic dysfunction. There will be diastolic dysfunction in hypertrophic cardiomyopathy. And then I didn't tell you how a vignette on hypertrophic cardiomyopathy is going to look like. These people are going to have sudden cardiac death. These people are going to have sudden cardiac death. During exercise, most of the time. Right? During exercise. That's probably what they will give you as a vignette. And they'll be young. Okay? Young person. A young person. Then we talk about dilated cardiomyopathy. So you're going to have a systolic dysfunction. Dilated cardiomyopathy is often as a result of gene mutation. I don't know what's going on with my pen. It's as a result of a genetic mutation. Mutation generally in titin. A mutation in titin gene. A mutation in titin gene. There are also a number of things that would increase the risk of dilated cardiomyopathy. Things like hemochromatosis. So you're going to see that hemochromatosis causes both dilated and restrictive cardiomyopathy, but I want you to remember hemochromatosis only for dilated cardiomyopathy for this exam, okay? So whenever you say hemochromatosis, I don't want you saying both dilated and restrictive. I want you to say dilated cardiomyopathy because that's what is relevant for the exam. All right, we have other factors that also cause dilated cardiomyopathy, things like Chagas disease. If you remember, Chagas disease is the American trypanosomiasis, right? Trypanosoma cruzi, that is. Trypanosoma cruzi is the guy that caused Chagas disease. Coxsackie B virus. Coxsackie B virus is the most common cause of myocarditis after idiopathic. So if we don't know what causes it, the most likely cause is going to be Coxsackie B virus. And Coxsackie B virus will also cause dilated cardiomyopathy. Hyperthyroidism can cause dilated cardiomyopathy, especially when they develop thyrotoxicosis. You want to also remember that these are all causes of dilated cardiomyopathy. In dilated cardiomyopathy, you want to remember that you hear the S3 heart sound. You hear the S3 heart sound. Another thing you want to bear in mind is if this ventricle is supposed to look like this, your ventricle is supposed to look like this, there's aortic aorta coming out there, there's a valve here. If this ventricle suddenly stretches to become this wide because of dilated cardiomyopathy, what do you think happens to this valve? The valve is not going to stretch across, right? So the valve automatically moves away, right? The valve moves away and we get regurgitation. So in people with dilated cardiomyopathy, naturally, they're going to have valvular abnormalities. They are going to have mitral regurgitation, right? And mitral regurgitation is going to be a systolic murmur. If you remember that, systolic murmur. Remember one other information that is very important, that pregnancy is a hypervolemic state. Remember that phrase, pregnancy is a hypervolemic state. So when people are pregnant, they increase their plasma volume, they increase the volume of everything in the blood, and that can actually contribute to weakening the heart and causing dilated cardiomyopathy. So there are going to be women that their doctor would advise, I advise you not to get pregnant, because if she gets pregnant, she's very likely to develop dilated cardiomyopathy. And that is what we have, right? That is what we have. You look at this heart, you see how big it is. It looks like a big balloon. So somebody saw this on, when you do a chest x-ray of their heart, for example, you see the heart very big like that. We call that ballooning appearance. Balloon appearance. of the heart on chest X-ray. All right. So that is that for heart failure. Does anybody have any questions so far? I've kept you guys way longer than we thought we would be able to go. So I would like to actually give you a, I don't know if I don't want to end this at this point. Can you guys hear me still? Please let me hear from you guys in the comments. So we still have a number of things I would like us to cover. We would go all the way and finish up with infective endocarditis. When we finish with infective endocarditis and rheumatic heart disease, I'll let you guys go for today. And then I would communicate with you guys how we are going to finish up. And we have to also do respiratory system before the week runs out. So we'd need to set all of those up. I think I'll just have to find an additional class for all of you. And we'll do that. Within the week, we'll find a way to organize that within the week. Because one very extended class may be a lot for you guys to take in. All right. So that was it for heart failure, dilated cardiomyopathy. The last type of cardiomyopathy that you need to know is going to be restrictive cardiomyopathy. And the name pretty much gives it away, right? The name pretty much gives it away. It's restrictive. The name gives it away. It's restrictive. What does it mean? There is something outside the heart, compressing the heart, holding the heart, stopping the heart from expanding, relaxing. Usually it's going to be fibrosis, like what we saw with pericardial fibrosis, chronic pericarditis, right? That type of fibrosis. It may be as a result of radiation therapy. So if someone has like a thyroid cancer and then they have radiation, you go to treat their thyroid cancer and you irradiate their thyroid gland. It's right there, right? So in the process, you can also get to the heart, which is obviously going to happen. That increases their risk of developing fibrosis around the heart and restrictive heart disease. Amyloidosis is going to be a big one. Sarcoidosis is going to be a big one. And you want to remember all of those. Children get something we call, what's the name? Endocardial fibroelastosis. Children get endocardial fibroelastosis. Here, they're just going to give you a child with thick endocardium. That's what you're looking for, thick endocardium in a child. We also have low-flash endocarditis. Low-flash endocarditis, you're just going to see eosinophilia. You remember the last place we saw eosinophilia? I hope you're thinking of Dressler's syndrome, 2 weeks after an MI at least, right? All right. And that is what we have. That's restrictive cardiomyopathy. The next thing we'll talk about quickly before I let you guys go is going to be a little about the management of these guys. So if someone has dilated cardiomyopathy, your goal is to remove fluid, as much fluid as possible from their blood, right? That's what you're going to be trying to do if someone has dilated cardiomyopathy. We'll talk about that. We'll talk about pharmacology. We want to look quickly into infective endocarditis. Infective endocarditis. We have two types of infective endocarditis. We have acute and subacute. I'll be very fast on this part, and so that you guys can get a break. Acute and subacute endocarditis. What is acute endocarditis? It's endocarditis that is affecting a healthy heart. That's how I want you to think of it. A very normal person can develop acute endocarditis. The organism, the bacteria that causes this is Staph aureus. Staph aureus is the organism or the bacteria that causes acute bacterial endocarditis. Staph aureus can damage normal valves. It is virulent enough to damage normal valves. The question becomes, who gets Staph aureus endocarditis? Very important. IV drug users. Because IV drug users inject themselves. Staph aureus lives on your skin. It also lives in your nose. We'll talk about that in micro. But Staph aureus is also present on the skin. So when people inject themselves, what happens? They can introduce Staph aureus into their blood, and then their veins are going to carry this blood back to the right heart, and they'll get Staph aureus endocarditis. Whenever Staph aureus is causing endocarditis, one of the things you want to know is that there will be large vegetations. Large vegetations. Vegetations are those things that accumulate on the valves, okay? Large vegetations, those things that accumulate on the valve. And these vegetations are largest with Staph aureus. They can dislodge. So look at this. Your right ventricle, your right atrium is here. Your right ventricle is right there, and it's going to pump blood into the pulmonic trunk. And the pulmonic trunk will pump that blood into the lungs. So if you have a large vegetation on your right ventricle, right here, this vegetation can dislodge and end up, the vegetation is on the valve, the tricuspid valve. It can dislodge and end up in your right ventricle. From your right ventricle, it's going to be pumped into your pulmonary artery. And from your pulmonary artery, it can go to the lungs. As it travels along these blood vessels to the lung, it will get to a point where the blood vessel is small enough. This embolus, this vegetation, can occlude a blood vessel and actually cause pulmonary embolism. So you want to know that with acute bacterial endocarditis, they may give you a patient with pulmonary embolism, but they don't have DVT, right? They don't have any deep venous thrombosis. They are IV drug users. And they ask you, where is the thrombus coming from? It's actually because this patient has acute endocarditis, and that thrombus has dislodged from the tricuspid valve and is headed for the lungs and can cause pulmonary embolism. The second type of endocarditis you want to know, of course, is subacute bacterial endocarditis. For subacute bacterial endocarditis, we are going to have multiple possibilities, multiple avenues, multiple things that will result in subacute endocarditis. For example, the most commonly spoken about one and commonly tested is going to be strep viridans. Strep viridans endocarditis is going to be seen in people who have undergone, I don't know, my pen is malfunctioning. I think it's tired. Okay, it's going to be seen in people who have undergone dental procedures. People that undergo dental procedures will get endocarditis from strep viridans. Other people can get endocarditis with other organisms. We have endocarditis from the HASEC organisms. You're looking for this in people with culture negative endocarditis. So you see someone with all the symptoms of infective endocarditis, we'll look at some of them eventually. And you do a culture and you don't see the organism. They'll tell you that in the vignette. They did a culture, they did not see the organism. It's because that organism is not one of the organisms that are easily cultured. It's one of the HASEC organisms. Specifically, it is this guy, the C in HASEC, Cardiobacterium hominis. Cardiobacterium hominis is the culprit, and this is a big guy. On your exam, you want to also remember that. They may give you a person with endocarditis with what? Strep bovi. If they give you strep bovi endocarditis, you should think that this patient has colon cancer. They will give you endocarditis with strep or staph epidermidis. You should think that this person has a catheter. Somebody that has a catheter placed in them is going to be more prone to developing subacute endocarditis with staph epidermidis. These are common things they will test you on There are other types of endocarditis that we talk about. We talk about Liebman-Sack endocarditis, Liebman-Sack endocarditis in people with SLE, Liebman-Sack endocarditis. We talk about non-merantic, non-thrombotic endocarditis. Those ones are not so important, actually. These ones on this part are more important. Strep viridans is super important. Asec organisms, this question shows up a number of times. These guys also may show up on your exam. We treat strep. All your strep are treated with penicillin. So they may decide to ask you, what could you have done to prevent the endocarditis in this patient? And the answer would be, give amoxicillin, right? The answer would be to give amoxicillin or a form of penicillin before the dental procedure as prophylactic therapy. Do you guys get that? And then you have all these mnemonics that you use. I think you have mnemonic in your first aid that says from Jane or something of that nature. There are a number of symptoms that we have in people with endocarditis. You can look at your first aid and memorize those things if you want to. It's not very important to memorize them. Okay, finally, we talked about rheumatic heart disease. We've mentioned rheumatic heart disease a number of times. So we'll just talk about it briefly. Rheumatic heart disease. When we talk about rheumatic heart disease, you're thinking to yourself, what does it mean? What does it entail? What does it involve? The most important thing is going to be that they'll give you someone with a history. Oftentimes, they will give you the history. History is most commonly of sore throat. They may give you a history of a skin rash, a condition, something of that nature. With that history, they're going to tell you now that the person has developed a new murmur. The same thing here, you probably have someone with a new murmur. Of course, they're going to have a fever. They're going to have all those additional symptoms you have in endocarditis, like your Osler's nodes, your Janeway lesions for subacute endocarditis, that is. They'll have fever, they'll have rot spots in the eyes and all that. For rheumatic heart disease, however, you probably still have a murmur. The mnemonic was what? What's the mnemonic you use for the major criteria? I think Jones, you guys have this mnemonic like this. The Jones criteria, yes. The Jones criteria. They'll have joint pain, multiple joint pain. They'll have carditis. That's what this heart represented. I think they have multiple lymphadenopathy, if I remember this mnemonics correctly. Okay. And what does they have? Sydenham chorea. What's the E for? I think that has skipped my mind. And then they have something that this E actually represents. You have all these symptoms that you use to actually diagnose rheumatic heart disease. The most important thing is that you pick up on the history if they give you the history. The second thing is that you know the mechanism of the disease. It's a molecular mimicry kind of response. It's basically the body looking at the heart and thinking the heart looks like strep. And so the body attacks the heart. Remember that these people have a strep infection, so they'll have increased ASO titers. Increased ASO titers for strep. And then what the body is reacting to is molecular mimicry to M protein. The way to have prevented this would have been to give this person penicillin or a form of penicillin. Penicillin is how you treat every strep infection. The next section is actually where we begin to talk about vasculitis, the different types of vasculitis, aortic abnormalities. Then we go into important pharmacology, and we would be done with cardiovascular system.